लाइव कर दिया ना। है। हेलो। ठीक है, ओके। ओके, कोई दिक्कत नहीं, ठीक है। मेरे को होस्ट बनाओ।
How will we on this? कैसे चार्ली?
हेलो।
Good morning, all. The respected Director, Dean, SK Sir, Shantanu Sir. Greetings to all. I stand before you today with immense joy and gratitude as we gather to inaugurate this CME on RV dysfunction, right ventricular dysfunction, hosted by our Department of CVTS SGPGI. This department was founded in 1987 and we are on its sixth CME. Through this CME, we aim to focus on the critical aspects of right ventricular dysfunction, fostering multidisciplinary teamwork, as well as exploring new about RV functioning and novel approaches to treat RV failure. Hereby, I would like Dr. S.K. Agarwal sir to come on the dais for the further inauguration. And I would also like Dr. Deeman sir to come on the stage to light the inaugural lamp. Now I would like Dr. S.K. Agarwal to come on the dais and declare the CME open.
Actually, my role is to just welcome you all to the sixth CME of the Department of CVTS. Although this is almost 37th foundation day of this department, but we started observing it only in 2015. And in between, because of COVID and other problems, we could not hold it for 3-4 years. So this is the sixth CME. And the power and the to open this CME rest with the director. So I will request director sir to come and say a few words and open the CME.
Thank you, SK. Professor Shalin Kumar, our Dean, Dr. Pandey, and Dr. Verma, my dear colleagues, ladies, gentlemen. जहाँ तक CME open का सवाल है, I open CME. Thank you so much for inviting me for this role also. जहाँ तक फाउंडेशन डे की बात है, मैं यहाँ पे ज्वाइन किया फरवरी 2020, तो नेक्स्ट ईयर से कोविड के साथ में ही हम लोगों ने डिसाइड किया कि हर डिपार्टमेंट का एक फाउंडेशन डे होना चाहिए, जैसे हर इंस्टीट्यूट का एक फाउंडेशन डे होता है। SGPGA का जो फाउंडेशन डे है वो 14 दिसंबर है, और आपका भी एक फाउंडेशन डे है। कुछ लोग मेरे को मिले, कहने लगे हमें तो पता ही नहीं है कि फाउंडेशन डे क्या है, कब है, कब स्टार्ट हुआ। तो मैंने कहा यू डिसाइड जो आपको कन्वीनियंट है वो आपका फाउंडेशन डे है। बेसिकली फाउंडेशन डे क्या है? फाउंडेशन डे इज इक्वल टू द बर्थ। ह्यूमन का बर्थ होता है, यू ऑलवेज रिमेंबर योर डेट ऑफ बर्थ। फिर उसके बाद में हर साल आप अपना बर्थडे सेलिब्रेट करते हो, पीछे का रिव्यू करते हो, आगे की बात सोचते हो। एंड सिमिलरली इज द फाउंडेशन डे ऑफ एनी डिपार्टमेंट और एनी इंस्टीट्यूट। हम आज ये सोचते हैं कि हमने पिछले, जैसे बता रहे हैं, 35-37 साल में हमने क्या किया और आगे की हमारी विज़न क्या है, मिशन क्या है, हमारी प्लानिंग क्या है, वो बहुत इम्पोर्टेंट है। पीछे का जहाँ तक बात है वो तो डॉक्टर एस.के. अग्रवाल ही बताएंगे, दैट आई डोंट नो मच। लेकिन जहाँ तक फ्यूचर की बात है, डॉक्टर एस.के. अग्रवाल और डॉक्टर शांतनु पांडे और उनकी टीम, दे आर प्लेइंग ए वेरी इंपॉर्टेंट एंड द ग्रेट रोल ऑल्सो। और मैं देखता हूँ कि आने वाला जो भविष्य है इस डिपार्टमेंट का वो बहुत ही ब्राइट है। उसका रीज़न मैं आपको बता देता हूँ। आपका अभी तक जो था, एक डिपार्टमेंट था जो एडल्ट पेशेंट्स को देखता था और कभी कभी जो है पीडियाट्रिक पेशेंट्स को देखता था। तो आपके पास 60 बेड थे, ऑपरेशन थिएटर्स थे, आप कॉम्प्लिकेटेड सर्जरीज करते थे। आई नो ईच एंड एवरी फैकल्टी मेंबर इज कैपेबल ऑफ डूइंग द कॉम्प्लेक्स सर्जरीज ऑल्सो। लेकिन कॉम्प्लेक्स सर्जरीज अवेलेबिलिटी के साथ साथ में प्लानिंग करना बहुत ज़रूरी है टू अचीव द मैक्सिमम और आई वुड से द ऑप्टिमल आउटकम। तो उसके लिए आपको पूरा डिपार्टमेंट की प्लानिंग करनी पड़ती है कि कौन से ऑपरेशन डेज हैं, कौन सी ओपीडीज़ हैं, कितने पेशेंट देखने हैं, कितना का ऑपरेशन करना है। तो ऑल दोज थिंग्स एक्चुअली में दैट इज़ फॉर द एग्जिस्टिंग स्ट्रक्चर और जो भी आपका है। बट इन फ्यूचर emphasis has been given to the pediatric sector also। आपके 70,000 बच्चे जो हैं हर साल प्रॉब्लमेटिक होते हैं यूपी ऑफ स्टेट में, जिसमें 25 करोड़ जनसंख्या है। दिस 70,000 दे आर बोर्न विद द कंजेनाइटल हार्ट डिजीज एंड मोस्ट ऑफ देम दे आर विद द complex diseases also। but the most important thing is कि they are treatable। आप उनको ट्रीट कर सकते हैं, दे कैन लिव ए नॉर्मल लाइफ एक्सेप्ट द फ्यू, बट मेजॉरिटी आई वुड से मोर देन 90%। लेकिन अगर आपके पास ट्रीटेबल चीज़ें हैं तो उनको ट्रीट करना चाहिए, उसकी फैसिलिटी आनी चाहिए। तो ऐसे में ही एक दंपति है, मतलब कपल है, हिमांशु सेठ और मिली सेठ फ्रॉम सैन होजे कैलिफोर्निया। तो उनकी बिटिया की भी डेथ ऐसे ही हुई थी इन द एज ऑफ द 13-14 ईयर्स। शी वॉज सफरिंग फ्रॉम द कॉम्प्लेक्स हार्ट कंजेनाइटल हार्ट डिजीज़। पहले यहाँ पे हुआ, फिर यूके में, यूएसए में गए तो 3-4 मल्टीपल सर्जरीज, बट शी कुड नॉट सर्वाइव। दे बिलोंग टू द यूपी। देन दे थॉट कि यूपी में अगर इतनी बर्डन है, प्रॉब्लम है बच्चों की जो कि ट्रीट हो सकते हैं, कर सकते हैं, तो उन्होंने कहा कि हम जो हैं एक सेंटर बनाएंगे, वर्ल्ड क्लास सेंटर बनाएंगे, जस्ट लाइक स्टैनफोर्ड यूनिवर्सिटी ऑल्सो। वो लोग पहले भी गए दूसरी पहले यूनिवर्सिटी में, जैसे पीजीआई रोहतक वगैरह में, बट दे वर नॉट हैप्पी। सो वंस दे कम ओवर हियर दे वर एक्सट्रीमली हैप्पी कि हम यहाँ पे ओपन करेंगे। दे डिसाइडेड एंड ए प्रोविजनल MOU वाज डन इन USA व्हेन आवर फाइनेंस मिनिस्टर और उस समय हमारे चिकित्सा शिक्षा मंत्री भी थे सुरेश खन्ना जी, एंड मैनी अदर ब्यूरोक्रेट्स, एंड दे टुक मी ऑन टेलीफोन एंड देन वी डिड ए MOU, 1 पेज MOU कि हम लोग यहाँ पर करेंगे। उसके बाद आगे चलते रहे एंड नाउ ये तो हिस्ट्री है। अब हम लोग आगे बढ़ रहे हैं। तो ये था कि 2 फेज में ये सेंटर ऑफ एक्सीलेंस फॉर चिल्ड्रन बोर्न विद कंजेनाइटल हार्ट डिजीज़ बाय द स्लोनी फाउंडेशन, हार्ट फाउंडेशन। जब ये कहा गया कि हम 2 फेज में करेंगे और फर्स्ट फेज, उसी समय मैं फ़ोन पे था, कैन यू प्रोवाइड अस द 30 बेड्स? आई सेड यस। तो मेरे को मालूम था आपका बी साइड का एकदम तैयार हुआ, तो हमने कहा कि कर देंगे उसमें। एंड सिमिलर थिंग व्हेन आई टॉक टू द S.K. अग्रवाल एंड शांतनु पांडे, हमने तो कहा, उन्होंने तैयार कर दिया। आज आप देखते हैं तो फेज 1 इज ऑलरेडी इन द डिपार्टमेंट ऑफ द कार्डियोवास्कुलर सर्जरी। 30 बेडेड आपका वार्ड है, और साथ में एक ऑपरेशन थिएटर एंड 6 बेड आईसीयू। आई थिंक वी मस्ट अपलॉज फॉर देयर वर्क, both S.K. Agarwal as well as Shantanu Pandey and their team also. They are moving forward. That is the most important thing. You need not to get a pace from the very beginning. The only thing, the starting is as important as the completion also. So well beginning is half done. तो आधा काम तो इन्होंने कर ही दिया है जहाँ मैं समझ, अब इसको पूरा करना है। एंड आई रिक्वेस्ट ईच एंड एवरीबडी टू हेल्प दिस कॉज, और इसको करना चाहिए मेरे हिसाब से। तो इस फाउंडेशन डे का जो भी हमारा होना चाहिए कि लक्ष्य होना चाहिए, तो ये आप इस चक्कर में ना रहें कि 3rd या 4th फाउंडेशन डे है। हैड आई बीन योर प्लेस, जब से स्टार्ट हुआ अब तक 35वां फाउंडेशन डे, वी विल से इट इज़ द 35th फाउंडेशन डे, क्योंकि बर्थ ऑफ द डिपार्टमेंट और एनी पर्सन और एनी ह्यूमन बीइंग और एनिमल जो भी है, तो जो बर्थ होता है वो डेट फिक्स होती है, तो वहीं से भी हम मानते हैं। बीच के आपने नहीं बनाया तो बात अलग है, बट इट इज़ द 35th और द 36th फाउंडेशन डे, ये मान के चलिए और आज का प्रण याद करके चलिए। एंड गो हेड एंड ऑल द बेस्ट टू यू एंड योर टीम। थैंक यू सो मच।
Now I would like Dr. Shaleen to come on the mic and say a few words, please.
Director sir has set the stage and set the bar very high. I will add another layer to the story. The purpose of medicine is of course to cure. हम चाहते हैं कि कोई आए तो उसको हम ठीक कर लें, but when the cure cannot take place, कुदरत की वजह से जो भी reasons हैं, when cure cannot be take place, people suffer, चाहे वो बच्चे हों चाहे वो वृद्ध हों, and heart disease is no exception. एक सर्जरी, 2 सर्जरी, ये दवा वो दवा, उसके बाद सफरिंग बहुत शुरू हो जाती है. Fortunately now there is a new science. There is not a new science, there is a new rethink. Ki how do you manage symptoms? And this is the skill of palliative care. So cardiac palliative care for those whom we cannot cure, unke liye this is a new layer that is coming, and I would urge that in the Saloni Heart Foundation for pediatric and currently for the vast majority of adult population, those people, the symptoms of cardiac dysfunction are straightforward. You have edema, आपकी सांस फूलती है, पेट फूल रहा है, water retention हो रहा है, breathlessness हो रही है, anxiety हो रही है. Without addressing the पैथोफिजियोलॉजी तो कर दी जितना कर सकते थे, जो कारण है उस पर जब नहीं ठीक कर पा रहे हैं तो there is always possibility to relieve and mitigate symptoms and improve the quality of life. That is the science of palliative care, because it is not the case that what cannot be cured should be endured. Of course, you endure it, but you can always make it simpler. You can always ease the exit of the person or make the life more meaningful. That is as important, if not more important, than the cure that we give. So I would urge the team to also consider your vast people, the people towards the end of life. End of life is something that we say in the last 1 year of their life. That is called end of life care. And for that, there is capability in this institute to offer it to you, and some of us can come forward and join hands in this very noble endeavor of yours. And I wish you all a very good, a very fruitful deliberation today. Thank you very much.
I would like Dr. S.K. Agarwal sir to felicitate Dr. Dhiman. Dr. Shaleen, please. And I would like Dr. Shantanu Pandey to come and just say a few words for the vote of thanks.
Good morning and welcome all for this sixth Foundation Day CME. This is 37th Foundation Day. 36th Foundation Day. Yeah. So, so I welcome you all and I thank you all for taking out time so early in the morning to attend this session of right ventricular deliberation or right ventricular dysfunction. I thank Director Sir for being here so early in the morning and gracing the occasion and giving us the spirit south. Thank you very much, sir. I thank Dean Sir to be here early in the morning. He was the first dignitary to have arrived here. Thank you very much for being here and supporting our cause. And we take your words very seriously. So once we have ironed out our performance, our results, we definitely would think about helping patients with more compassion and care as you have suggested. So I thank the organizers of this CME, the people who have been behind organizing this CME, the residents, the fellows in the department, the co-faculty members, the nurses who have been very supportive for conduct of this CME, the students of perfusion who have been here and have been very supportive of this CME. And in the last, I would like to welcome, and in absence, I would like to welcome the speakers who are going to come and talk about the different aspects of right ventricular dysfunction in the CME. I especially welcome those who have come and thank them, those who have come from outside the city to take part in this CME. So one of our very senior alumni, Professor Dr. Lalit Kapoor sir, he is a professor to me. He has been here in the morning. So thank you very much, sir, for being here. And at the end, I would thank my industry partners who have very ethically contributed to success of this CME. Thank you very much.
So we now disperse for a short tea break. Thank you.
एक बार वहाँ ट्रांसफर करने का नाम हो गया नीचे ट्रांसफर 200 का है वो हमने थोड़ा करती है अमित शाह वाले डॉक्टर जगह पूरा रोड पे पड़ा हमने क्या कर सीखा उससे आगे नहीं आ रहा आएगा जो शुगर डालता है फेना हटा के दूसरा कप दो शुगर हम खुद ही कराते हैं पानी फिर देखना आएंगे टेबल से हटाने ये भूल गए थे तो बताया ना आपको। नहीं, हमने कल बताया ना, मुझे बोलो ना, आपका बोनस बोला, हम सुन रहे हैं, आपको कितने आए? तो वो हम भूल जाते हैं, लगा देते हैं। आधे घंटे बाद आए। तो बात है। हमारे वकील साहब हमारे पीले ने बेटी भाई खाने में भाई आकर साथ बोले हाँ मैं तो यही चार को जो काली ठीक है जाए बाय। ठीक है चलिए पानी पानी आप वाटर के ऊपर नहीं डाल या ठीक है
Share, share. अच्छा, हाँ जी सर, गुड मॉर्निंग। बढ़िया सर, बताइए कहाँ है? ले लिया, सब हो गया, रेडी है, सब चल रहा है। ना ना ना, कुछ नहीं, नहीं नहीं नहीं, कोई इशू नहीं है। ठीक, ओके। कनेक्शन सब हो गया। ठीक सर, ओके। एक सेकंड, कहाँ गया? नहीं शेयर किए हैं वो, शेयर नहीं हुआ क्या अभी तक? एक काम ना करें, हो गई, एक और है, एक मेल ये है आकाश। ये एक कंपनी के 3 हैं, दूसरी कंपनी
तीसरी होगी।
बस ये ध्यान रखना अपना अनम्यूट वो हरदम रहे। ठीक है, ये चल रहा है। एक फोल्डर बना ले डेस्कटॉप पे। नीरज ध्यान रखना म्यूट अनम्यूट का अपना।
फोल्डर ये जो है इसमें, ये इसको क्या है, ये इसमें ना इस तरीके से। एक सेकंड, इसको मैं फिर फोल्डर दूंगी। शिफ्ट कंट्रोल एक्स डेस्कटॉप। न्यू फोल्डर बना दूंगा। आज की 4 मई ना।
तो डेस्कटॉप पे डाल देंगे क्या, या फिर प्रेजेंटेशन है मेरा?
अच्छा,
जी पीपीटी।
ये ना। सर यहाँ मिलेगी।
ठीक, एक बार ओपन करके देख लीजिए चल रहा है कि नहीं चल रहा है।
कर दीजिए ऊपर।
ठीक, पहला मेरा है पेन ड्राइव। हाँ मेरा है। गुड मॉर्निंग। अरे उस दिन आपको फोन किया था ना एक्चुअली। अरे
कल 2 बजे तक के बीएल वाले को बैठने रहते हैं ना,
वो बैठेंगे सब लोग, कोई वहाँ टिकने वाला नहीं है, सब
वो कुछ इंस्ट्रूमेंट के वो जो टेंडर है ना,
हाँ।
बस जी तो मैंने बीएल वाले से पूछा कितने बजे तक बैठे थे, कहते रात के 2 बजे।
नहीं तो उनको बोल लीजिए कि वो 6 बजे ही आए, ऑफिस शुरू होती ही 6 बजे है। अरे हर कोई, हम लोग तो खैर परेशान नहीं है, लेकिन बाकी रेजिडेंट्स स्टाफ इतना परेशान है।
वो कोई डॉक्टर रेजिडेंट है, आनंद आनंद करते हैं।
सौरभ करके है, सुबह के 4 बजे तक तो बैठे रहते हैं।
केस कब तक चल रही है?
वही प्रॉब्लम तो है ही। निकालिए अपन ड्राइव।
बिल्कुल पढ़ना चाहिए कि आपकी। और इसको मैं फर्स्ट पेज से रन कर दूं।
डेस्कटॉप नहीं रखिएगा।
डेस्कटॉप के ऊपर साइड, लेफ्ट साइड में।
ठीक,
बेटर इसलिए क्लोज कर। कोई प्रेजेंटेशन अगर मेल पे देते तो डाउनलोड करके तुम भेज तो सकते हो।
मैं मेल ही खोल दूं ना, मेल खोल देता हूँ।
मेल भी खोल लो, व्हाट्सएप भी खोल लो।
सर मैं खोल रहा हूँ प्राइवेट
जो
चीज।
भी वैसा म्यूट कर लो।
तो है।
तो खोलो, ये बड़ा बड़ा
क्या
ये कर देना। है अब अन्य
यही SIC का है। अच्छा सर, आज ही फिल है।
इससे पहले बायोपोर आता था ना FedEx से AOA 14 और क्या था रैपिड में तो AOA 14 से क्या था कि कैल्शियम का डिपोजिशन होता है वो और कम हो रहा था एक्सपेक्ट करना सो एपिड वाज
सही राइट कर कैसे कंफ्यूजन ना हो, नाम डाल उसमें। प्रशांत। ठीक है,
इशू वो बाइंडिंग
श्रीनिवासन।
सब
आदमी जो बोल रहा होता है Good morning, everyone. Beginning our academic session for today. The first session is on the topic of exploring functional differences between the right and the left ventricle to better understand the right ventricular dysfunction. I would like to call the chairpersons for the same. Dr. Amir Mohammed, who is the Assistant Professor of CTVS from AMU. Dr. Munshi, who is the Assistant Professor of Department of CVTS, SGPGI. Dr. Shantanu Pandey sir from the Department of CVTS SGPJ itself. And I would request Dr. Lalit sir to come on the stage to chair this session, please. Yes, sir.
So, till this arrangement is changed, you are better watch for chairperson to sit because we'll be obstructing your view and we'll not be able to see anything. So we'll sit on the chairs till this arrangement is made again. So I will call Dr. Navneet to start his first talk while they make this. Ah. Yeah. टेबल को साइड करना पड़ेगा, चेयर पे तो बैठेगा ना।
Good morning. Good morning. First of all, I would like to thank CVTS department, SGBGI, for giving me opportunity to present on this academic feast. As we all are here to celebrate the foundation day of the department, and the topic of the CME is most forgotten ventricle, the right ventricle. So why is it said so? Because was this said before, it is younger brother of the left ventricle. And all this because of the fact that it has been assumed that it function as a passive conduit, and it is less important member of the contractile function. Pumps blood only to one organ, that is lung, and less frequently involved in diseases of epidemic proportion such as myocardial infarction, cardiomyopathy and valvulopathy. But years ago, English physician Sir William Harvey, who established the circulation physiology in human being, was the first to describe the importance of right ventricle. He mentioned in his book in 1616 about the right ventricle as, thus the right ventricle may be said to be made for the sake of transmitting blood through the lungs, not for nourishing them. And for many years that followed, main emphasis in cardiology was placed in LV physiology. overshadowing the study of right ventricle. And after that, first half of the 20th century, RV study mainly limited to a very small group of investigators. And they made the hypothesis that the human circulation could function adequately without RV contractile function. And after later on, between 1950 to 70, cardiac surgeons recognized the importance of right ventricle as they evaluated procedures to palliate the right heart hypoplasia. And after the evaluation of echocardiography and MRI and so many different investigating tools, since then the importance of the RV function has been recognized in heart failure, RV infarction, congenital heart diseases, and pulmonary hypertension diseases. So my presentation will cover brief embryology of the heart, how RV develops, basic anatomy of the RV, and how it differs from the LV functionally to better understand the RV dysfunction. As we all know, the vascular system as well as the blood elements are mesodermal in origin. So after 18 days of fertilization, some specialized cells from the splanchnic mesodermal proliferate and form a cell cluster called angiogenic clusters or blood islands. These are situated at the cranial end of the embryonic disc. Gradually over time, they migrate laterally and form a horseshoe-shaped cluster of cells. They later form the cord of cells called the cardiogenic cords, and they later recanalize to form the two endothelial heart tubes, right and left, at the 20th day after fertilization. After 21st day after fertilization, the two tubes fuse together and form a single tube, that is from cranial to caudal. At the 22nd day after fertilization, this single tube develops gradual dilatations, series of dilatations. From cranial to caudal, these dilatations are bulbus cordis, primitive ventricle, primitive atrium, and sinus venosus. So the junction of bulbus cordis and primitive ventricle is called bulboventricular sulcus, and the junction of primitive ventricle and primitive atrium is called atrioventricular canal or atrioventricular sulcus. Bulbus cordis is most cranial part of the heart tube, and we can divide this in three parts: distal 1/3 towards the cranial, middle 1/3, and proximal 1/3 of the bulbus cordis. This distal 1/3, that is the most cranial part, gives rise to ascending aorta and pulmonary trunk. Middle 1/3 of the conus, middle 1/3 of the bulbus cordis, that is called conus, forms the outflow part of the both ventricle, left and right. And proximal third, that is the lower third of the bulbus cordis, actually give rise to the right ventricle. So right ventricle develops from the lower third division of the bulbus cordis, and left ventricle develops from the primitive ventricle dilatation of the heart tube. The junction of the bulbus cordis and primitive ventricle later develops in the interventricular foramen and later in interventricular septum. Primitive atrium forms the both auricles, left and right, and anterior trabeculated part of the both atrium, left and right. So over the time, the single heart tube gradually curves, initially in U-shaped and later on in S-shaped, in such a way that the arterial end, that is the most cranial part, comes anteriorly, and the venous end, that is the caudal part, goes upward and behind the arterial end. And at the 5th week of gestation, the single heart tube looks like in this picture. This is the bulbous cordis part, the most cranial part, that is the proximal 1/3, forms the aorta and pulmonary trunk. Middle 1/3 conus part forms the outflow of both left and right ventricle, and the proximal third of the bulbous cordis forms the right ventricle. Primitive ventricle dilatation forms the left ventricle, and primitive atria forms the both auricles and left and right atrium. Now RV anatomy. So on cross section, right ventricle is crescent shaped chamber, and topographically and traditionally it has large sinus portion that surrounds and support the tricuspid valve, includes the apex, and as a whole called the inlet portion, and a smaller infundibulum that supports the pulmonary valve called the outlets portion. Both inlet and outlet valves are widely separated, but practically Gur and Lille described right ventricle in 3 parts: the inlet, the trabeculated apical myocardium, and infundibulum or conus. So the entire sinus portion and most of the infundibulum are coarsely trabeculated. In this picture we can see that the sinus portion supports the tricuspid valve and includes the apical trabeculated myocardium and a smaller infundibular part. Infundibular part is partly trabeculated and partly smooth. There are 3 important muscle bands in the right ventricle anatomy. These are parietal band, septomarginal band, and moderator band. Parietal band is actually rightward extension of infundibular septum. It gradually merges with the right ventricular free wall and forms the ventriculo-infundibular fold. Parietal band with infundibular septum together forms the crista supraventricularis, which separates the pulmonary valve from tricuspid valve as well as from aortic valve. So the basic difference between RV and LV by anatomy is that in RV, conus doesn't regress, but in LV it regressed, so that there is a aortic mitral continuity. Septomarginal band situated on the septal surface of the right ventricle, and anteriorly it continues as a moderator band to the free wall of the right ventricle. That gives rise to the anterior papillary muscle that supports the anterior leaflet of the tricuspid valve. Posterior limb of the septomarginal band gives rise to the medial papillary muscle that supports the septal leaflet of the tricuspid valve. There is a clinical situation in which parietal band, infundibular septum, and septomarginal band together with the moderator band hypertrophied and divide the right ventricle in 2 parts: large inlet portion and a small outlet portion called double chambered right ventricle. So in this picture we can see the lower attachment of the septal leaflet of the tricuspid valve in RV as compared to the mitral valve leaflets, and there is a monitor band seen in the RV. Superficial fibers of the RV and LV are attached together. Now, myoarchitecture of the ventricles. The ventricles are not made up of a single muscle fiber or single muscle bundle of cells. It is a three-dimensional network of myocardial cells. And they are highly structured, arranged in layers in which the myocardial cells have a preferred orientation. So the left ventricle having 3 layers of arrangement of fibers, and right ventricle having only 2 layers, that is superficial and deep, left having an additional middle layer. Superficial and deep layers of the ventricle attach to the ventricular orifices to the fibrous structure of the central fibrous skeleton of the heart. Middle layer is unique only to the left ventricle, and it is in circumferential pattern. And there is no plane of fibrous separation are present between these 3 layers. The separation is only by their way of orientation and arrangements. When we unwrap the right ventricle from the left ventricle, we can see the orientation of fibers in different way. So the superficial fibers of the RV and LV are attached together. In RV, it is usually circumferentially arranged parallel to the AV groove, but at the sternocostal surface, it is oblique and attached to the superficial fibers of the left ventricle. Middle fibers are absent in the RV, and in the LV, it is circumferentially arranged. And deeper layer in RV as well as in LV are longitudinally arranged. So when the fiber arrangements are different in both ventricles, so the way of contraction is also different in both RV and LV. The contraction of RV is sequential in nature. It is peristaltic pattern. Usually contraction starts from the inlet portion, goes to the trabeculated myocardium apex and ends at the infundibulum. As compared to RV, LV contracts like a torsional pattern. Its contraction is like a squeezing or wringing of a towel. So there are 3 separate mechanisms for RV contraction. The first is inward movement of the free wall, like bellows effect, contraction of longitudinal fibers that displaces tricuspid wall towards the apex, and there is a traction on the free wall at the point of attachment secondary to the LV contraction. As we have discussed that the superficial fibers of the RV and LV are attached together. So when LV contracts, it pulls the RV free wall and helps in maintaining of the RV output. So the shortening of RV is greater longitudinally than radially. So in this picture we can see the way of contraction of both RV as well as LV. Because of bellows effect, that is inward movement of the RV free wall, there is high ratio of RV volume change to the RV free wall surface area change and allows the right ventricle to eject a large volume of blood with little alteration in RV wall stretch. But there is a specific feature of RV contraction is that it poorly adapted to the generating high pressure. When we differentiate RV and LV on pressure volume loop, so we can study pressure volume loop of the LV as when we start from the C point, that is the in-diastolic volume where mitral valve closes, end of the filling phase where mitral valve closes, and from C to D is the isovolumic contraction. And at the D point, when aortic valve opens, there is a ejection phase, that is the E phase. And at the F point, when both aortic valve as well as mitral valve close. So from F to A is the isovolmic relaxation phase. At the A point, when mitral valve opens, gradually LV fills and there is a filling phase of the LV. So the pressure volume loop of the LV is like a rectangle shape. When we compare it with the RV pressure volume loop, it is triangular or trapezoidal form. Isovolmic contraction and isovolmic relaxation periods are very ill-defined in case of RV. And in RV there is early peaking and rapid declining pressures. Regarding RV hemodynamics, RV is coupled with the very low impedance and highly distensible pulmonary vascular system. When we compare the right pressures with the left ventricular pressures, it is very lower as compared to the left. And there is a special feature called hangout interval during RV flow. When we compare both pressures in LV and RV, it is very much high in LV as compared to the RV. And the term hangout interval is a time duration during RV outflow. We can see in this graph that even RV pressure is lower at this point, but the blood flow is continuous from the pulmonary artery to the lung. And it is because of lower impedance and peripheral vascular resistance of the lung. RV systolic function is reflection of preload, afterload, or contractile function. And its performance is also influenced by the rhythm of the heart, synchrony of the ventricular contraction, and ventricular interdependence. So preload. Preload is usually defined as it is the load placed on resting muscle that stretches it to its functional length. So in case of ventricles, it is the end-diastolic volume that is the preload. But usually it is difficult to measure the volume, so we surrogate it with the end-diastolic pressure as a preload of the both ventricles. So what is the difference between RV and LV? Filling. RV filling normally starts before and finishes after LV. The isovolmic relaxation time is also shorter as compared to the LV, and the filling velocities E and A and the ratio of E and A are lower in RV as compared to the LV. There are also many factors which influences the RV filling, such as intravascular volume status, ventricular relaxation, ventricular chamber compliance, heart rate, LV filling, and pericardial constants. So some special features to the RV filling is that it accommodates varying degree of preload while maintaining a stable cardiac output and normal filling pressures. And it is because of two special characteristics, that is the distensibility of its free wall and better compliance. RV is usually well tolerated for the volume overload, but in case of volume overload, there are two situations that leads to the symptoms to the patient. That is the functional tricuspid regurgitation and compression of the LV by the mechanism of ventricular interdependence. Afterload. It is the tension against which the muscle contracts. So in case of RV, afterload having low impedance and highly distensible pulmonary vascular system. So afterload of the RV is the PVR, but there are many factors which influence the PVR. That is hypoxia, hypercarbia, and many other molecular pathway such as nitric oxide pathway and prostaglandin pathway that causes vasodilation, and endothelin pathway that causes vasoconstriction. If we compare sensitivity to the afterload of RV and LV, we can see that RV is very sensitive to the afterload. Even slight increase in afterload decreases the stroke volume. But in LV it is gradual. And we can see this is in clinical situation of pulmonary embolism. We can also see the effect of PEEP on preload and afterload of the RV. In this model, we can understand the effect of PEEP on preload and afterload. If we consider central vein as a blood level represents the CVP and water level represents the PEEP. If CVP is 5, then right arterial pressure is 5 and RV pressure is 20, PA pressure is 12. The situation when we raise the PEEP above the CVP. Now PEEP is 7. So in that situation, there is decrease in preload. And because of decrease in preload, there is decrease in cardiac output. But in this situation, RV function is maintained. And we can treat it by giving either volume to the patient or by other mechanism by decreasing the PEEP. There is another situation when PEEP is more than CVP as well as more than PA pressure. So in that situation, preload is decreased as well as RV afterload is increased. And that is the situation when RV fails. AV synchrony is also very important for the RV function. So there is a clinical situation such as acute RV myocardial infarction, acute pulmonary embolism, or chronic RV failure that poorly tolerate the atrial fibrillation or complete AV block. We have also seen that post-operatively when there is a RV dysfunction, atrioventricular pacing helps the patient. There is term ventricular interdependence. This concept says the size and shape and compliance of one ventricle may affect the size, shape and pressure volume relationship of the other ventricle through direct mechanical interactions. So it is in the form of systole or diastole. As we have seen in previous slide that both superficial fibers of LV and RV are connected together. So systolic interaction is by interventricular septum and continuity of muscle fibers of the both ventricle. In diastole, it is mainly through the pericardium. So in clinical situation when RV pressure or volume overload states, there is dilatation of the RV and shift of septum towards the LV, which alters the LV geometry and increased pericardial constants. That results in the LV diastolic pressure volume curve shift upward and decreased LV preload as well as LV in diastolic pressures and results in the low cardiac output states. So when we compare right ventricle and summarize it with the left ventricle, we can say RV is thin free wall, LV is thick free wall. RV is crescentic in cross section, LV is circular in cross section. RV having coarse apical trabeculations, LV having fine apical trabeculations. RV having 2 layers of muscle fibers that leads to longitudinal shortening. In LV it is 3 layers of muscle fibers that leads to torsional contraction. RV is very sensitive to pressure overload, LV is sensitive to volume overload. RV usually requires lower energy cost to maintain output. LV requires high energy cost to maintain output. So maintaining same cardiac output, RV requires 1/5 of energy as compared to the LV. During coronary circulation, 50% oxygen extracted from the blood in RV, 75% extracted blood from blood in LV. RV having shorter action potential duration, LV having longer action potential duration. RV having alpha MHC expression and leads to faster shortening velocity, LV having beta MHC expression and leads to slower shortening velocity. Alpha adrenergic stimulation reduces contractility in RV. In LV, it increases contractility. Most of the coronary blood flow occurs during systole in RV, but in LV, it is mostly during diastole. So this is the basic functional anatomical differences between RV and LV. Thank you.
Thank you so much, sir, for an enlightening presentation. The house is open for questions.
Thank you. You didn't touch upon how these things would affect the patient or physiologically. These are all basically anatomic and the physiological things. But how does it change in pathology? Does it do with validation, thickness of the muscle? Does it increase? Does it decrease? What happens in different conditions? You were not able to cover that. For example, physiology, muscle thickness. So what happens to the RV contraction at that time? Does it change? How does it affect it?
Sir, my presentation has to cover only basic anatomy and physiological differences. It will cover in later presentation.
Question. I also presented RV anatomy and physiology when I was doing MCH. It's a very nicely prepared presentation. Where we have reached today regarding the understanding of RV physiology has a history of more than 400 years. I remember reading somewhere that the first concept of RV function was given by, I think, Sir William Harvey in 1600.
1616, I am a son.
Yeah. And initially it was thought that RV's function is just to nourish the lung. But he was the first person, I guess, who proposed this concept that it's just to pass the blood through the lung coming to the left side.
I am a son in the first slide.
Yeah. It's a very nicely made presentation. It covers the history, the embryology, and the everything.
Thank you. Thank you.
Adding to my knowledge, I don't have any questions.
If somebody has any questions or comments, I think we should proceed further. Thank you very much, Naveed, for beautiful presentation.
Thank you, sir.
We deal with this national issue as well.
Thank you, sir. Thank you.
I now request Dr. Varuna ma'am to felicitate our speaker, Navneet sir. I now request Dr. Varuna ma'am to felicitate our chairpersons. Dr. Lalit sir. Dr. Shantanu sir. I now request Dr. Munshi to felicitate Dr. Amir sir. I now request Dr. Avnin to felicitate Dr. Munshi. Thank you so much. Now moving on to our next presentation, the pathophysiology of the right ventricular failure. I request the chairpersons to kindly come on the stage. Dr. Jigar Shah, is he here in the auditorium? Dr. Ravi Kumar, who's our PDF SR in minimally invasive cardiac surgery in SGPJ. Dr. Ashish Jha, who's the senior consultant cardiologist from Cherak Hospital, is he here in the auditorium? Dr. Harshit Khare, who's the assistant professor of cardiology in Department of Cardiology in SGPGI. I request Navneet sir to kindly chair this session because the chairpersons are not here. I request the speaker, Dr. Shahid Abkari sir, to kindly come on the stage, on the podium, and he is the professor of pediatric cardiology from AMU. Over to you, sir.
Good morning, everybody. At the outset, I would like to thank Department of Cardiovascular Thoracic Surgery from SGPJ Lucknow for giving me this opportunity on speaking on right ventricular failure pathophysiology. And when this topic has been allotted to me by Dr. Varuna, actually, she called. So I thought, why is it a forgotten ventricle? Because being a pediatric cardiologist, our primary concern is on right ventricle only. So definitely left ventricle is one thing which gets involved, but whether we are deciding about the operability in a patient of a congenital heart disease or a post-op management of a tetralogies got stuck because of right ventricular dysfunction, our primary concern is only at the right ventricle. So again, I thank the Department of CVTS for giving this opportunity to speak on this topic, and my topic will be predominantly from this guideline, which has been a scientific statement which has been published in 2018 from American Heart Association with the evaluation and management of right-sided heart failure. So it's a very comprehensive guideline. You can go through it. And why is it so concerning that right ventricular failure involves the congenital heart defects, even in patients with pulmonary artery hypertension, and it's because of this a vicious spirals of right ventricular failure. So once it right ventricle develops failure, the course is quite downhill. The natural history dramatically changes in a congenital heart disease if the patient develops a right ventricular failure. So embryologically, I will not be touching much about the embryology part because it has been comprehensively covered by Dr. Navneet. So, but what is important that embryologically, definitely the right ventricle and the left ventricle are different because the left ventricle originates from the primary heart field and the right ventricle, right outflow tract originates from the secondary, the anterior heart field. That's the primary difference. And anatomically also, the right ventricle is quite thin with a compliant and a heavy ellipsoid shape that adheres to the left ventricle. And it's has a typical funnel-like configuration, very highly tuberculated.
and the presence of crystal ventricularis, which separates the right ventricular inflow from the outflow. So what you get aortomitral continuity in our left ventricle, we don't have that as a tricuspid or pulmonary valve continuity. So there's a clear-cut infundibulum which is there. Beginning with that knowledge, whenever there is a right ventricular failure or right ventricular dilatation, the geometry changes very dramatically. Okay, so this is a shape which you normally get when which the right ventricle adheres the left ventricle, covers anteriorly. When it dilates, it takes a very unusual shape and it dilates in this fashion. So what is the most determining factor as being covered by Dr. Navneet, that it's the primary dependent factor for the right ventricle is the presence of what is the status of the afterload. And the right ventricular ejection fraction is inversely proportional to the pulmonary artery pressures. Higher the pulmonary artery pressures, the ejection fraction decreases. And as we will discuss, it follows the Starling curve. And as the blood ejects from the right ventricle into the lungs, the antegrade flow from the pulmonary valve encounters a wave of reticulate flows generated by multiple bifurcation within pulmonary circulation. So it created a resistance. So this retrograde impedance wave reduces the antegrade flows and increases the pulmonary artery systolic pressure. And of course, the left ventricular filling pressures involves directly the right ventricular outflow, reducing the compliance and increases the PA resistance. So there is a concept what is known as ventricular artery coupling, in which under steady state the ventricular insufficiency is achieved by end systolic elastance, which is matched by the vascular resistance in the form of arterial elastance. So the ratio of this end systolic elastance to the arterial elastance is known as ventricular arterial coupling, and the optimal coupling for the right ventricular function to work normally corresponds to 1. Anything going below it means that there is a uncoupling which is happening and it will dramatically affect the right ventricular function. So this slide has been shown by Dr. Navneet already, but what is very important to see that the increase in afterload is very poorly tolerated by the right ventricle. There's a dramatic fall in the stroke volume as the pulmonary artery pressure increases. So as there's an increase in pulmonary artery pressure, RV function becomes insufficient and more energy expended to maintain the adequate right ventricular outflow, which is being depicted again because if you give more volume to it, the right ventricle dramatically fails, which is known as right ventricular falling off the Starling curve. So pathophysiologically, I will be discussing about the right ventricular failure into acute versus chronic. And the acute right ventricular failure, there are two causes to it, two reasons to develop acute right heart failure. One is there's an abrupt increase in the right ventricular afterload, which happens in the case of massive pulmonary embolism, hypoxia, and acidemia. Or a patient's second cause, which is they're developing decreased right ventricular contractility, especially if patients with right ventricular ischemia, myocarditis, or post-cardiectomy shocks. So normally right ventricle is coupled to a high compliance, low resistance pulmonary circulation, and it is more suited to the changes in the volume. So it can accommodate amount of volume, but it cannot accommodate an increase in pressure. Okay, so any rise in the pressure inside the pulmonary circulation will dramatically decrease the right ventricular compliance and decreases the right ventricular outflow, stroke volume. So as we discuss this mechanism, it's a chain of events which triggers the right ventricular failure, and the right ventricular myocardial injury leads to more of myocardial inflammations, as happens in myocarditis and ischemia, which results in the stroke volume, results in right ventricular dilatation and more of a tricuspid regurgitation, which further exacerbates the right ventricular dilatation. And it drives what is being described earlier, that is the ventricular interdependence. It is, mind you, the most important reason for filling of the right ventricular stroke volume. failing of the right ventricular stroke volume. So, and then further mechanical flattening of the left ventricular side of the interventricular septum increases the left ventricular end diastolic pressure and decreases the LV filling, which increases the NV end diastolic pressure and which further contributes in the systemic hypoperfusion. So, another concept which is important, which has been earlier also discussed, is the diastolic interaction. That there's what is known as a ventricular competition for the diastolic filling between the left ventricle and the right ventricle in a very confined pericardial space. Again, any elevated filling pressures on the right side also causes the coronary sinus congestion, which decreases the coronary blood flow and provokes RV ischemia. And high right-sided pressures and with systemic basic congestion also negatively affects the hepatic and renal functions and aggravating further fluid retention and worsening the right heart failure. So this has been discussed in the previous lecture also, that, and it's again I would reiterate the fact that this is the most important reason for a falling of the right ventricular stroke volume, in which increase in right ventricular pressure leads to shifting of the interventricular septum to the LV, leading to an increase in LV and diastolic pressures and leading to systemic hypotension. Another important reason for failing of RV is this RV myocardial perfusion, which has been affected. And there's a concept that RV systolic perfusion pressure, that is the perfusion pressure of the coronaries supplying to the RV myocardium, is dependent on the systolic blood pressure minus the pulmonary artery systolic pressure. So any degree of change in either of the two will lead to dramatic. So if there is an increase in pulmonary artery pressure, systolic pressures, there's decrease in the perfusion pressure. If there is a fall in the systolic BP, there's again this perfusion will be affected. So it's perfusion of the right ventricle is dependent on the pressure gradient between the coronary arteries, the systolic blood pressure and the right ventricular pressure. So any degree of systemic hypoperfusion. So especially if these are very sensitive patients, likely a patient with the RV compromised function, if you're doing a intubation or doing any medication which transiently decreases the pressures, systemic pressures, it dramatically shifted the balance and the patient starts to have decreased cardiac output. So right ventricular failure leads to volume overload, it leads to systemic congestion, leading to elevated central venous pressure, reduced systemic perfusion pressure, and further leading to organ perfusion and leading to occult organ failure, especially involving the kidneys, the brain, liver, bowel. And this is the whole, I'm sorry about that because I have taken the slide from this that article, but what is more important that this is the same vicious cycle or vicious cycle of the right ventricular failure, which involves, and there are multiple reasons to it, that there is increase in the RV afterload leading to right V dilatation, more of a TR, leading to more septal shift towards the LV side and leading to decreased LV cardiac output, but decreases the blood pressure and involves the coronary perfusion and leads to more of a RV myocardial perfusion of the myocardium to be compromised. So this is the whole, I will not again repeat that thing, but which is important, that this is the whole vicious cycle. So one event triggers the other and leads to a vicious cycle. Then coming on to the chronic right heart failure, and the predominant reason for the chronic right heart failure we see is because of chronic pulmonary artery hypertension. I will discuss in one slide on that also, but it happens because there is a gradual increase of RV after caused by the pulmonary hypertension, and chronic volume overload from the right heart sided lesions like tricuspid deviation and lead to compensatory myocyte hypertrophy and fibrosis, and if the loss persists for long, it leads to myocyte loss and replacement by fibrosis. Of course, right ventricular dysfunction happens to secondary to left sided cause. I will be discussing the causes again. And the first and foremost cause for the chronic right heart failure is chronic pulmonary hypertension, and this is a classification which has been, so I will not go into the details of the what are the causes of the chronic pulmonary artery hypertension, but like we divide into 5 classes and label it as chronic pulmonary hypertension basis on the cause to it. First, of course, the pulmonary artery hypertension. Second is because of secondary left heart diseases. Third, to lung causes. And then there are some pulmonary artery obstruction and unclear or multifactorial causes. So classically, though this division is not so like it's not very discrete, but we sometimes divide it into as a forward failure and a backward failure. So forward failure means the RV is not able to generate adequate cardiac output, leading to cardiogenic shock, and forward failure because it increases the systemic venous pressures in the systemic venous system, leading to increases CVP and systemic congestions. And then stages can be in the form of, to start with, the patient will have a systemic congestion and subsequently will have hyperperfusion, but the blood pressure is somehow maintained by the RV. But once this event continues to be there, it leads to frank hypertension and shock. And this is an important slide in which the causes of right heart failure has been divided into acute and the chronic one, and which further being divided into because of the involvement of right ventricular contractility or right ventricular volume overload, or because of the pressure overload. So acute, we all know, with one of the important causes is patient developing any sort of right ventricular MI or myocarditis with sepsis, or because of the pressure overload, one of the important causes patient developing hypoxia, pulmonary embolism, massive pulmonary embolism. While in chronic, because the RV contractility can be affected by because of the cardiomyopathy or because of ARVD. Abstinence anomaly involves both decreased ventricular contractility as well as there's a increased volume overload because of TR which is happening, and RV contractility or this is affected because the whole thing, the premise in the abstinence anomaly is how much is the functional RV, how much is the atrialized RV, and how much is the functional RV which is being there. Then there is other congenital heart disease which I will be discussing, which can involve right ventricular failure or can lead to right ventricular failure because of the volume overload. The pressure overload can be because of one important cause is right ventricular outflow tract obstruction in the form of pulmonary stenosis, which we see a lot of patients coming from an neonatal period in the form of critical pulmonary stenosis to rather asymptomatic patients coming in adolescent age group with dyspnea class 2. It could be because of chronic thromboembolic disease, or could be because of left-sided valvular heart disease or restrictive cardiomyopathies. As little discussion about the involvement of right heart failure due to the left heart failure, and as you know, the left heart failure has been divided into 2 groups, like that is because of reduced EF or the preserved EF. And what is important that the prevalence is quite high of the right ventricular involvement in patients with both with reduced ejection fraction as well as for the preserved ejection fraction. They say that's one of the study from Mayo Clinic have found that there is almost 48% right ventricular involvement patients with left heart failure because of reduced ejection fraction. And what is more important that in both these categories, the involvement of right ventricle have a bad prognosis in the form of requirement of transplantation or left ventricular assist device or increased risk of mortality. And even utilizing us new modalities on echocardiography of like in the form of utilizing right ventricular longitudinal systolic strain, almost 75 patients with a patient with preserved ejection fraction have right ventricular dysfunction. Post-surgical, we see a lot of patients, and one of the more important cause being is the patients with developing right heart failure is because during a myocardial protection not proper or leading or hypoxia during intraoperative period, microembolism, arrhythmia is important cause, or sometimes the volume control is not good during the intra-op period, patient develop, or even in the post-op period develops excessive volume and leading to right ventricular dysfunction. So combination of both cardiopulmonary bypass and pericardotomy lead to reduce in longitudinal contraction and increase in transverse shortening. UVC is right ventricular dysfunction in patients even with cardiac transplantation. Some discussion on congenital heart defects, and as you know, the right ventricular dysfunction develops little late in patients with atrial septal defect. Though there is a volume overloaded right atrium, right ventricle, but dysfunctions typically develops in third to fourth decade of life. Abstain anomaly is one anomaly in which we see patients coming very early, and abstain anomaly, as you all know, that it can present at any stage of the life. They present even in fetus or during a neonatal period, during early childhood, and during later on as a RV dysfunction. And the whole presentation or whole involvement of right ventricle is dependent on the degree of right ventricular hyperplasia and how early and how successful the tricuspid valve reparative surgery has been performed. Transposition of great arteries, we see transposition of great arteries in patients with LTGS who develop RV dysfunction, especially because here the right ventricle is the systemic ventricle, so it starts to fail by third to fourth decade of life, and it's also dependent on the presence of associated lesions like presence of left AV wall or the tricuspid valve regurgitation. In TGS, earlier surgeries which has been performed like Sening-Simonstat, the right ventricle was a systemic ventricle, so typically also with like case of LTGA develops failure by third to fourth decade of life. We see a lot of patients of DTGA coming to us with regressed left ventricle with dilated RV coming because of the delayed presentation. Of course, single ventricle physiology, whether operated, non-operated, especially patients with hypoplastic left heart syndrome typically develops failure of Fontan around third to fourth decade of life because the RV is a systemic ventricle, so it cannot sustain the systemic pressures for long. So they become symptomatic around third to fourth decade and first subsequently require a cardiac transplantation. Manifesting Bishkam, this was not discussion of my topic, but some important thing that the patient with a chronic right heart failure presents with increased fatigueness, with protein malnutrition, cachexia symptoms, and because of the congestive features will have even a side test pleural effusions. Okay. And these are some of the echo parameters. I'm not covering it because this has been will be covered in the subsequent lectures. But we utilize a lot of times. One important thing is, especially in post-op patient, we require utilize RE function by eyeballing. But TAPSE is one parameter which has been being utilized quite frequently. And definitely for pulmonary systolic pressures, we are using the tricuspid valve regurgitation velocities and looking for the IVC diameter and collapsibility, hepatic flow reversal, and any shift of the interlateral septum. Okay, I'll just jump on to those things because it's not my topic. But what I've been like, because I'm primarily a pediatric cardiologist, so we'll be covering some aspect of congenital heart defects. This is a classical scenario. This has been like we are struggling to extubate this patient. Like been operated almost 4 days back. Patient of tetralogy with a small pulmonary annulus, undergone a intracardiac repair with a transcendental patch, and definitely non-low cardiac output states with the borderline pressures and decreased urinary output. And this is a scenario. We just did the echo 2 days back. The patient is developing right ventricular dysfunction with significant degree of tricuspid regurgitation, and we're just struggling. So what we are continuing is that luckily this patient is getting a negative with peritoneal dialysis. So we will continue for 2-3 more days for intubation to continue, and we'll try to extubate her as early as possible. And of course, abstinence I will likely to cover because this is one scenario when patients with bad abstinence. But what we found that there was enough septal tissues and tricuspid valve tissue which was available to us. So the patient has a really bad abstinence with the pericardial effusion also. had undergone what is known as in the intraoperative period, that was really ballooning heart. The child has undergone a cones repair. It was the first cones repair which was being done at our institute, and it did fairly well actually after surgery. The child's tricuspid valve was functioning quite well, and everything has come down dramatically. Neonatal PS, we see a lot of patients coming with a critical PS with severe RV dysfunction. This is a patient which you can see that RV is hardly contracting, and the contractility really excuses me for the apex invert, because we normally take our echoes on with upside down. But you can see that the right ventricle is having dysfunction with severe tricuspid valve regurgitation. The LV contractility is good. There's a significant pericardial effusion. The child has undergone immediate, he was 2 weeks old with a severe RV dysfunction, with severe critical pulmonary stenosis, undergone balloon pulmonary alveolotomy, and definitely did well actually. Single ventricle with hypoplastic RV, this is a common scenario which we see a lot of patients coming to us. So we didn't have a problem in deciding about the really management of these patients, because subsequently these patients will go into single line ventricle. But what I want to discuss is the one which presented to us with a bit of borderline RV. The Z-scores of tricuspid valve around -2 to -3. The RV was good size but very hypertrophied, thick walled. So there is good inflow, tripartite, having good body, but very hypertrophied. So we did the angio. The angio, you can see the RV cavities is small. So the child has gone what is known as 1.5 repair, in which we have added a Glenn shunt to a complete repair also, because we want to offload the RV. We don't want to load the RV completely. This is another patient with single ventricle common AV canal, unbalanced RV dilatation, presented to us with pulmonary atresia. We did this PDS stenting this patient, which has been now going on the single ventricle lines. Now this is another, because I just added this because 2 days back only we did the angio of this patient. This is a 19-year-old coming to a first time with tricuspid atresia, and in this patient we did a RV angio, and we got, to our horror, what we found that there is absolutely no left pulmonary artery. So the RV is giving rise only to the right pulmonary artery. So we are just deciding on what's the plan we have to do in this patient, because unilateral Glenn is one thing which is very difficult to maintain. Our hypoplastic right heart syndrome is another scenario which we see quite frequently in patients. Just like a hypoplastic left heart syndrome, all the things are small. The right tricuspid wall is small, the body is small, the pulmonary annulus is small, the pulmonary arteries is small. So this is the one patient in which we did angio and found that our RV is completely very small. The PA annulus is hardly there, but good size branch pulmonary arteries. So we just had a discussion with the surgical team. So we just go ahead and did the stenting in this patient, and it did fairly well after the stenting. And though he was not much desaturating, but he was having much dyspnea and exertion. The child was very tachypneic, hypoxic in the form. So it did well after the RV stenting. So that's what. Thank you.
Afterload virus. What are the most common causes in preload?
For the preload, actually for the preload, you are talking about like post-op patients, or just like a de novo patient which you see a patient? Because mostly we see in a patient with post-op RV dysfunctions, the volume management is not so proper. So we, especially during intra-op management, and it, like, there are compounding factors, the myocardial protection by the CBP, and then subsequently the volume management and the use of the inotropy. So we see a lot of patients with preload RV dysfunction because of preload RV dysfunction post-op period. Like this patient we are suspecting because he has a transannular patch also. So there's definitely a pre-PR which is there, so it is contributing to the RV dilatation, and then the fluid management was not so good during the drop period, so it's like giving us tough time.
Any grading is there, sir? RV dysfunction? The mild, moderate grading?
No, there's no such grading, but definitely we use the autopsy parameters one in which they say that anything which is five less than five, say it's a severe form of RV dysfunction. But definitely we cannot utilize this the TAPSI because the TAPSI in pediatric age group the cutoffs are different. You use a TAPSI cutoff of less than 17 in adults, but in pediatric definitely the cutoffs are different and different for each age group. But for adults, you can say that anything which is TAPSI, which is less than 5, is a severe form of RV dysfunction or rather RV failure.
Decoupling sounds a very fantastic idea for capillary or pre-capillary disease. Pre-capillary is more considerable. Is there a simple way of now using this criteria in clinical use, or it is till now working only in physiology?
Yeah, so to be very honest, definitely I have gone through deeply in this concept by making this lecture only. Clinically, I'm not utilizing this coupling concept. So in our day-to-day practice, so definitely, looking at to the RV dysfunction and RV failure, we look for whether which is a pre-capillary or post-capillary. Just we look for whether it's what's the left heart involvement. But majority of my experience in the congenital heart defects is there. So majority of our patients are mostly pre-capillary. So they don't have. So honestly we are not utilizing this ventricular arterial coupling concept in clinical use. It's more of a.
So I try to use it in some kind of research. I thought of the calculation started very naively, but when the real calculation expanded, it was beyond my capability to even understand what function they are.
True, sir. So I
believe that that is more of to be with physiologists rather than and mathematicians rather than as a clinical.
Yeah, true, sir. Yes, sir.
But one more question about this pediatric cardiology and right ventricle failing. We all know the typical case of right ventricle failing is a pathology of that.
Yeah.
So have we been able to find some criteria pre-operatively to predict that this right ventricle is going to behave back post-operatively? Or is it only after surgery we realize that, oh my God?
So, but you all know, sir, the prolonged hypoxia, because we see patients coming to tetralogies even in adulthood. So, you see, the dictum is that delayed presentation, most patient having prolonged hypoxia for a prolonged, the RV has been exposed to a prolonged hypoxia, will tend to behave badly after surgery. Especially that's why the operating at adult tetralogy is always a very difficult task because they drain a lot and then they subsequently in post-operative they develop a lot of RV dysfunction. So we have not done I wanted to do our research on looking at RV longitudinal strain pre-operatively and how is it post-operatively, how is it improving. So far we have not done it, but what we have seen that more of a delayed position, more of a hypoxic patient, badly they behave, and especially they don't tolerate free PR. Especially the worst scenarios on patients having a free pulmonary ejection. That's why initially our surgeons were little aggressive in doing a transcendental, and now they become more conservative and try to preserve a valve as possible as well. Because the patient RVs was prone for a pressure overload. Suddenly you have provided a volume overload also. So suddenly it starts to fail also. That's the reason.
One final question from my end about ventricular interdependence to you and Navneet also. Both of you guys are ventricular interdependent. So is it still, do we consider that intact pericardium is important for that, or that concept is now?
So the concept of pericardial constraint is always there. So that's why both the ventricles compete for the space. And ventricular interdependence is definitely a very important because more of a flattening, more of a tenting or bulging of the interventricular septum bad the prognosis of the patients in this, because the RV will definitely will fail. I think, and tetralogies are one thing which we are also looking is, especially our tetralogies are coming a little late. We hardly see TGS coming as early as first month of life. Then TGS, what we are seeing, one important concept is looking into the interatrial septal bulge also. So if the atrial septal bulge is towards the left, towards the right side, this is a little reassuring because the venous return is more. But if the interlateral septum bulge is towards the left atrial side, then it's hazardous because this is now has gone to the obliterative permeatory hypertension. And so we like last month only we have operated one 11-month-old PJ had a bad outcome because of this pulmonary hypertension which that patient had. I think so.
Yes, interdependent is in two forms, systole and diastole. In systole, it is because of intermedullary septum and attachment of fibers of both LV and VV. And in diastole, it is because of the pericardium.
So if pericardium is voided, then one part will go away, the other part will go.
Both ventricles fight for the space.
Thank you.
Thank you so much, sir. I now request Dr. Varuna ma'am to kindly felicitate our speaker. I now request Dr. Munshi to kindly felicitate our chairpersons. Thank you so much. We'd like to move to our next session on should the tricuspid valve be repaired and on which echo criteria should you rely. I request our chairpersons for this session, Dr. Achal Dikshit. Is she here? I request Dr. S.K. Agrawal sir to kindly chair this session. And Dr. Jigar Shah, is he here in the auditorium? Dr. Vishal Srivastav sir, is he here in this auditorium? I request Dr. Varuna to kindly chair this session. And,
क्या है दोनों हो जी भाई सिंह बंद कर लाइट Okay, good morning, ladies and gentlemen. Actually, I just jumped in the middle because I have to go and means I may come in the dinner for an hour, but I have lots of things to do. So I'll just finish off with this one. And you know, when you talk about right ventricle and you talk about the right side of the body and right organs which are means get directly affected by the problems in right ventricle and all, then you cannot forget tricuspid valve, because tricuspid valve is one of the custodians which actually results in the disease progression, and it actually straight away, if there is leakage and all, then the stress on right ventricle increases many folds. And if you have a leaking tricuspid valve, then you cannot think of actually treating right ventricular in any way. So therefore, this valve becomes very important. Yes, we know that it is a very apically placed valve, It is the biggest valve. Annulus also is the largest. And this atrioventricular valve has got 3 leaflets. Now that is important because when you have a large annulus, large valve area, and 3 leaflets, then because right side is actually addressing to the low pressure systems. And if this kind of anatomy is there, then the leaks are bound to occur and they can move further up. And they can increase a lot, but still they may not cause problems, and the problems can emanate very late. Now we also know that right atrium is actually one of the most complicated structures because embryologically, if you look at how this right atrium develops, then there are so many absorptions, apoptosis of the embryological structures, and then only your right atrium comes into being. So it has lots of the things, and that the tricuspid regurgitation, if this leak occurs, then either it may be because of the structure per se of the tricuspid valve, there may be a perforation, there may be other problems of the tricuspid leaflets, or it may be because of the problems which are down the line, you see, in the lungs, in the left ventricle and all that. So these are called the secondary regurgitations. And in fact, it becomes very difficult to assess and also to actually offer therapy when you are talking about this. Then why this is important? Why we should actually address to tricuspid regurgitation? Because if you go back in the history, you see, like this paper I have included, 1994, right? So at least 3 decades back. So we knew that this leakage, it continues on, then probably it is making your RV more sick. And you can see that the survival is affected if there is tricuspid regurgitation, and if it keeps on increasing in severity, then it is more problematic. Now, the major reasons for the morbidity and mortality are actually whenever you have severe TR, because TR addresses again to the right ventricle. Whatever blood leaks into the right atrium, it comes back into the right ventricle. You see a vicious circle is made. And if this process goes on, then it will result in right ventricular dysfunction. It dilates. There is further up in the upstream area, you have IVC dilatations and its effect on the other organs like liver and all, because you may have the problems of that. So the right-sided system gets involved. And again, you can see here that in 2004, again, whatever papers have come up, they always have shown that if you have a leakage, right, and it has affected the right-sided chambers, then actually it affects the survival. Now, this is interesting because it is recent. In 222, there is one paper and others. See, right-sided symptoms. It is a Japanese study. They have looked into the certain parameters like P gradient, urea burn, and the albumin and the left atrial volume, indexed volume. So these parameters, if they have taken into consideration in the presence of TR, which is severe, then you can see they have built up a score, and this score has resulted, if all the systems are involved, means it is arising from the left ventricle and probably affecting the right side also, then if you have right-sided symptoms too early, then probably you have worse survival. And similarly, you can see that they have seen in this paper where there was tricuspid regurgitation in those patients who were treated for mitral regurgitation for any cause by putting a mitral clip, and also the transcatheter aortic valve involvement. So 2 different pathologies, but both of them resulting in the tricuspid regurgitation. Now, if they have seen it, they see that if tricuspid regurgitation is from moderate to severe, then you can see in this forest plot that actually it increases the mortality. So either the left-sided disease or the right-sided symptoms, if they are coming up, then actually they are increasing, in the presence of tricuspid regurgitation, they are increasing the morbidity and mortality. So how this, now we know that if there is a regurgitation, then forget that you can actually treat the right ventricular side or something like that. You cannot affect the morbidity and mortality unless you are going to address it. Now, how to address it? Yeah, see, surgeons will always say that, well, either it can be replaced or there may be a repair. And you know, there are now the catheter base, because since we have started understanding RV function in a better way and how it is affecting the survival, you see, lots of catheter-based procedures have also come in. But we will not talk about those. So what about the surgical repair and replacement? This is some data till 2014 from US. And you can see here that the tricuspid valve repair has always has been addressed in a better way as compared to replacement, you see. And in the mass cohort, you can see that they have done better. Repairs have done better than replacement. So, means whenever there is regurgitation, you have to actually look at the repair. And if this is the ABCD is the actually the progression of TR, you can very well see here that how we are going to actually address it. Because you get a TR. We know on the right side, it is all volume dependent actually ventricle, and how it changes, you give anesthetics. Patient is rather anxious. Patient has not eaten. Patient is coming in this weather from far away and has not taken any fluids. Do you think that you will get the same magnitude of regurgitation? No, it is actually not like that. You see, it keeps on changing. So when he lands in your lab, and you assess them, or comes into the theater and you assess them, you find what? They have said it is severe TR, and you find that there is no TR. So, shall we change our management? It's $1 million question. So that is very important. We have to be very careful about that. If you're not able to see any TR jet in the OR, but you find on the cardiologist list is there, that it is there, that you have to do everything. You have to reach that level of actually hemodynamics where that cardiologist might have addressed it. So it becomes very difficult. But still, you see, cardiologists still treat right-sided heart, you know, rather in a stepmotherly behavior, you know. They do not give too much, oh, that will be seen in the OR. That kind of sense still prevails. So the cardiac anesthesiologists and the surgeons, they have to really work in tandem to look into whether something has to be done for this regurgitation or not, right? So that is important. Now, we have to look at that how this regurgitation, if it is a secondary regurgitation, how it actually develops. The reason is we know that it is a tri-leaflet valve, and actually the septal leaflet, that area does not actually dilate. It is in the anterior and the posterior leaflet area that it dilates, right? And also we know that just like the mitral annulus, this annulus also is a saddle-shaped annulus. It means it has got nadirs and the peaks. That is important. And when this thing dilates, then actually it starts lifting up. And this saddle becoming straighter and straighter and straighter, right? And that actually results, or straight away, right, defines the magnitude of TR, right? We'll see it further. So this we have to understand, where it is doing that. And what happens? The famed surgeon's three-finger test to actually look at how much is the TR. They just place the three fingers and they say, no, it can be just left like that. I think we have advanced too much from that three-finger test, you know. And what actually it looks at, you see here, this is the tricuspid valve, and this is the line where actually the surgeon is inserting his three fingers, you know, and measuring that. But it's actually, you are slightly offshoot the annulus. you are not addressing to the whole annulus as such. And therefore, many a times, this assessment, just by putting 3 fingers inside the tricuspid annulus, and you know, it may be a 6 feet German surgeon, or it may be a Sri Lankan or an Indian 5 feet surgeon, you know. So the volume of fingers, 3 fingers, will be varying according to the height, you know, from the German to the Indian. And probably this is a very crude phenomena to actually go ahead with this. So how do we assess the second part of that? We do echo. In transthoracic echo, actually, these are the views, parasternal long axis, RV inflow view and parasternal short axis view. They are actually looking and cutting the tricuspid valve in these lines. And you can see in a single view, usually you don't get all the 3 valves unless you are placed in such a view where you are cutting the tricuspid valve in a transverse plane. You see, there are only 1 or 2 or 3 views where you can get this. Another thing very interesting is the tricuspid valves, leaflets, if they are not getting effective, if they are not thickened, and it is a secondary tricuspid regurgitation, then it becomes very difficult to look at those leaflets completely. Why? Because they are too thin. So it again becomes a very difficult thing, and you have to really play a lot on your echo machine to actually build up the views so that you are able to see the things. And with transesophageal echo, because we are actually using higher frequencies and we are sitting nearer to the tricuspid valve, so actually we are able to see the leaflets, the annulus, the mechanism, right, and all the papillary muscles, so that if we do a complete evaluation, then probably we are better placed with transesophageal echo. And these are all so many ways. I can just take you through few of these ones. You can see here, this is the right ventricle, and you can see here the tricuspid valve, right? And this is another view. It is a deep midesophageal 4-chamber view. Why deep? Because we are bringing into consideration the coronary sinus. And whenever there is coronary sinus, then actually it is the anterior and the posterior leaflets which we are looking here. You see, this is the anterior leaflet here, and here is the posterior leaflet. Okay, and you can very well see here, this is the septal leaflet, and it may be an anterior leaflet depending on where you are. So in a single cut, you will not be able to get these all the 3 leaflets. This is again anterior leaflet and the posterior leaflet. In this view, we have to know each and every view, and you can actually look at these one again, the anterior and the posterior leaflets, and looking at the tricuspid regurgitation of certain moderate, probably moderate degree and all. See, this is important. And in transgastric views, if we go in, there are better views, and you can actually look at, this is the 4-chamber transgastric 4-chamber view with the transesophageal echo, and here on this side is the tricuspid valve, you see, and we can assess the tricuspid valve. And here is one of the best views. I like this view a lot because it gives you a fairly, very accurate measurement of the annulus from here to here, and also the coaptation distance and coaptation length. See, it is important, you know, and I'll talk about this coaptation length in a minute. So it is important. It is actually a transgastric inflow and outflow right-sided view. This is the pulmonary valve, this is the tricuspid valve, and this is actually the aortic valve, and the ascending part of the, means the root and the ascending part of the aorta. This is the right atrium. So you are able to look at the right atrium as well. Now, in this transgastric view, you can have, as I said, you can have all the 3 leaflets. This is a short axis view. We always use that. Here is the septal, and here is the anterior, and this is the posterior leaflets. Now, you can see here, there's something is jumping in and out, but you are not able to see the leaflets. As I said, that they are so thin, the normal leaflets are so thin, they hardly look into it, you see, unless you put some color and see that, well, the color is not leaking or something like that. So this is important, but it gives you certain ideas because you have to tweak with the machine, and you have to bring in those leaflets so that you can measure the commissural distance, right, from a anterior leaflet to the septal, and from posterior to the septal, and anterior to the septal. All these commissural measurements become important when you are actually looking at the severity of tricuspid valve, right? And this is the measurement which I have done with various kind of intercommissural distances. So, what all we use these parameters to measure, you see. We always look at the right ventricle and right atrium, whether they are dilated or not, right? Then we use some color flow Doppler to look into the intensity of the, you can see here, the intensity of the jet, right? If there is turbulence and all, because they give you indirect ideas that this is not a normal jet, it is too turbulent because too much volume is just moving. It means it may be means moderate to severe or really torrential tricuspid regurgitant. You do certain measurements. You also look in upstream, especially in the inferior vena cava and the hepatic vein. What is the hepatic vein signature? So, right? So that is how that gives you a fairly good idea, even if you are not able to capture tricuspid regurgitation, or you may think that it is a mild structure. But if you are looking at the hepatic vein and the inferior vena cava, and you are addressing it, right, carefully selected in a way so that your physics is fine and accurate, then you can say that, well, though I'm not able to get that, but still this is the thing, you can document that this patient has got moderate, severe, or torrential regurgitation. Again, one thing is important, that on the left side, many a times you get jets which are actually, because they are not centrally placed, but eccentric. Now, on the left side, we always say, if there is an eccentric jet, then it always depicts a severe regurgitation. But that does not hold good on the right side because of the large area, large annulus, 3 leaflets, right? So there may be any kind of movement in any side, and because it is actually a low pressure system, so loss of energy, which we talk about on the left side whenever there is regurgitation, that does not hold good for the right side. And therefore, we never take these eccentric jets. Actually, we look into other things. Then the other very important thing which we are getting nowadays on our echo machines is X-plane view. Means in the same cardiac cycle, at the same point, you know how the tricuspid valves are bleeding at 2 coronal and sagittal planes, you see, so that you are able to actually correlate a better area. So you measure both of them, and then you can average them out. Similarly, you can see here in this transgastric view, you can actually see few of the leaflets. And one more thing has happened. That is the advent of 3-dimensional echocardiography on our machines. Now that has made wonders, you know. You can actually start looking at tricuspid valve in altogether a different perspective. The leaflets are visible. You can see here, this is our, in one of our patients, 3-dimensional structure. See, you can see the leaflets and very well you can assess. I'll show you a few of the things, what we can do. This is another one where there is lots of problems with this. Another thing is the annular dimension changes throughout the cardiac cycle. This thing also is very important, right? So you have to be very careful about that where actually you are measuring and what point you are measuring. Otherwise, you have to take, and if there is any kind of arrhythmia, then again it will affect your regurgitation, and that is important that you take at least 6, 7, 8 normal cardiac cycles, and then only you can measure, then you can be accurate. Now we again come back to the 3D evaluation, because I do a lot of 3D evaluation. Whenever I have doubts, I go for the 3D evaluation. That is important. So why should we look at a single dimension and say that, well, this is 40 millimeters and you have to repair? Because that is our guidelines. That 40 millimeters, if there is a distance, right, AP and SP distance, well, you go ahead with repairing it, right? We have come up because then we were looking at the tricuspid, this tetralogy of Fallot, so many patients. Then we looked at actually the whole annulus, right, by three-dimensional thing. And exactly we looked at the area, and you can see here that 15.38 and 10.93. This is the diastolic and systolic areas. And if we can have this kind of measurement, then actually it becomes easier to assess that, well, whether you are able to get tricuspid regurgitation or not. But on the basis of this, you can say that, well, this patient needs to be ringed. Some ring has to be placed and all that. But the thing is that this actually needs proper large study to actually come up with. But it is fascinating, and I think we can do it. Let's play with these 3D pictures, you see. Now, let me show you. Now, this is actually a 3D rendition, LAN phase view, and you are actually looking at, the red one is the tricuspid regurgitation. This is, we have turned the heart down, right, and looking from the right ventricular side, and you can see here, this is the regurgitation. Now we can play around with these clips, right? So now we have played. Now you look here, I have really cropped it and all, and you can see here, this is how the leakage starts and goes into the right atrium, right? We can measure this. But in a single dimension, again, you are using a 3D picture and going for a single dimension, man. No, this is not accurate. It is better. Why don't you go for a three-dimensional structure? Look at the whole area. And that's what we have done here. And you can see, actually, this is the area. And the area is around 2.01 centimeters square. This is the leakage of tricuspid valve, right? So this needs to be addressed. Okay? So three-dimension has really changed our things. The other important thing which will come in, we know that right ventricular index we are measuring. That tells you that how much it has dilated. Equating to that if it is a severe TR, then naturally all the volume in diastole will go back into the RV, and RV keeps on actually swelling up. And this is affecting the left side also if it affects the septum in between, because both the ventricles share a common septum. But the other thing which is coming in is right atrial volume index. It also becomes very easy, though they have not put up as a right atrial index, but we can use the same thing the way we do for the left atrium. Here I have actually tried to measure this right atrial index, and it comes to around 76.9 mils per meter square. The normal we take, if we average man and woman, then the normal is around 221 milliliters per meter square. So this is actually nearly 3 times that. It's a huge right atrium, right? And how this right atrium grows? Only because lots of leakage is there. So probably we will, again, I think in the coming years, we will be looking into it as one of the best indicators, you see, why to go anywhere else. Well, there are other areas like vena contracta, PISA, but they usually are not used. And then there is management based on these one, right, whether you repair or you change it. I don't go with that. What I have summarized is that severe TR, TB repair, mild to moderate TR. If it is a severe TR priorly known, then go for repair, right? And if annulus dilatus in 40 millimeters, then TB repair, annulus diameter. If less than, supposing pulmonary artery systolic pressure, more than 50, TB repair. But I do not agree to it, right? Because you see, pulmonary artery systolic pressure, because you are measuring it from the tricuspid valve, means it is just like fishing, right? You sit on the bank and try to catch fish in the midstream. Well, that kind of thing, probably, it may hold good there, but it's not that good here, you see. We have to look at, if you directly translate into that probably TR is so big, no. You have to look at the right ventricle also, because if right ventricle is hypertrophied, what is about the septum? If all those things are bad, then only you can think of. If they are not, then probably you give them a chance. You try to take away this PASP, treat them either medically, or if they need a kind of surgical treatment, then actually probably after 6 months, after 1 year, you can think of actually assessing that. Now, we all know that still surgically it is all undersizing, right? 28 to 31, whatever, everything ends with this kind of ring and all, right? But you have to be very careful. When you place a ring, then these are few of the slides to actually tell you what tethering means. You place a ring, right? And see, the tethering is that you have to look at the coaptation length. So coaptation area, the coaptation distance, and the coaptation length. These three parameters are extremely important whenever you do this kind of thing. Now, if this kind of patient is there, now if you place, there is hardly any coaptation. If you place a ring, do you think that you will be able to make the leaflets coapt? No, it will not, it will fail, right? Something has to be done in the subvalvular apparatus and all that, if you are thinking of actually repairing this valve. Or it is better, taking all the morbidity and mortality of replacement, you can straight away go to the tricuspid valve replacement. So actually, we always look, because you see, when it dilates, as far as coaptation is concerned, for the coaptation, the length of the leaflet actually reduces. So that reduces the coaptation length also. Here you see, this is the tricuspid valve, and the coaptation length is only 0.3663 millimeters. We need at least 7 millimeters of coaptation, this coaptation length, then only this valve will hold good, right? It may not be leaking after your repair in the OR, but after 6 months, it will just give way. So it's very important that we have to look at and understand the phenomena of coaptation, right? So important thing here, you can very well see with an example, severe TR, a ring was given, but actually it only ended with post-surgical moderate TR, right? It will go to the laboratory and it will become severe TR. So if there is coaptation distance, loss of this coaptation length, then you have to be very careful and find out, discuss the subvalvular pathologies. There may be involvement of papillary muscles, there may be involvement of chordae tendineae, and those things have to be addressed in some way or the other. So in conclusion, functional TR is difficult, to analyze. Still, we go by the dictum of 40 mm of the measurements, but it is better you do a measurement in at least two orthogonal planes so that you remain correct. 3D assessment, I think the future will be 3D assessment on the right side, right? Tricuspid valve and all that, and right ventricle also. Right ventricle is also a very peculiar ventricle, the kind of ventricle is that. So assessment of right ventricle is also difficult. So all those things will be addressed very well by 3 dimension. Always remember that the parameters which we use on the left side, probably they are not as good on the right side. And especially the IVC and hepatic flow, vein flow structures are important, right? And one more thing, as a parting shot, I must say that always talk about the coaptation length, right? What is the coaptation length? If it is too less, then probably only the ring will not help. Thank you very much for your attention.
On this topic, and hopefully we'll not be giving the stepmotherly treatment to tricuspid valve anymore. It was really
पैजामा पहन के और वहां चलना है। बाहर चलना है बच्चे। कहाँ गए? पैजामा पहनो। और मैम ने पूछा कल कितना में आना है, पूछ के आना। चलो पैजामा पहनो कल। बात प्लीज, मेरे पास टाइम नहीं है, मेरे को हॉस्पिटल भी जाना है। जल्दी जल्दी, मैं बैग ले लिया दिया मैंने आपको। पानी पियो, मैं जा रहा हूँ। चलो पहन के आओ। क्या दवाई इतने तो कम पड़ेगा, हटाओ ना। क्यों रखा है ये पेन पे? मुझे लग रहा है मम्मा सिल के दे देगी। हम्म लो, मम्मा से चलवा लेंगे काम कर। जल्दी आओ। वेट नेट पर करने में इतना टाइम। जल्दी खोलो यार, कितना टाइम लोगे? बाहर बाहर आओ। इवान क्या कर रहे हो इतने देर से? हाँ? जब सुसु बैठ गए हो तो पहले नहीं बोलना चाहिए था कि मैं सुसु पॉटी करूंगा।
आवाज नहीं आ रही सर। करो, आवाज खोलो। अच्छा। पूरा दिन कितना आरवी पे पढ़ाएंगे? राइट वेंट्रिकल चल रहा है, मतलब टॉपिक ही राइट वेंट्रिकल है। अब मेरी आवाज नहीं जा रही है।
हमारी वीडियो जा रही है, हमारी आवाज जा रही है।
अब हमारी बात जाएगी।
सर उसमें ऑप्शन आ गया।
हाँ बिल्कुल आ गया है ना।
Your voice is not coming. You are not audible.
It's a very bad combination. This is just implying that right ventricle dysfunction has progressed so much, either systolic or diastolic. Diastolic dysfunction is equally harmful as systolic dysfunction. That the post-capillary pressures have increased. The right ventricle has stopped responding to increased post-capillary pressure and it started becoming dysfunctional. This dysfunction is giving rise to tricuspid valve regurgitation. So it's a very long route which it is taking, and it must have taken longer years for this. So this is a patient who doesn't have a very good prognosis, but nonetheless aortic stenosis is severe. They should be operated. But again, what Dr. Puneet said is most important. You should know before taking patient and decide if the patient is having difficulty in coming out of cardiopulmonary bypass, what drugs are going to use, what options do you have in your hand. Be ready with mechanical circulatory support, the protocol of mechanical circulatory support, at what indications are you going to remove it. Our experience with one mechanical circulatory support is decide preoperatively the criteria when you are going to remove it. Because if you put on right ventricular support, everything looks good. Everything's become settled. What criteria are you going to use to remove this mechanical circulatory support? So all these things need to be decided with cardiac anesthesiologist before you take this patient in for surgery. That will improve the outcome of the person. So if we are just going as we go for routine surgery, maybe the outcome may not be, because then you will be searching for something which will not be available in your pharmacy store. Thank you.
I request Dr. Varuna to felicitate our chairpersons, please. Speakers. I request Dr. Varna to felicitate Professor D.K. Srivastava, sir. Dr. Vijay Agarwal, sir. Dr. Puneet Goyal, sir. There's a slight change in the schedule. The next presentation is the right ventricle in the TOF correction. I request the speaker, Dr. Vijay Agarwal, sir, kindly come on the dais. And the chairpersons for this session, Professor Banani Poddar, ma'am, Head of Department, Critical Care Medicine, SGPJ. Dr. Mukesh Tripathi, sir, Senior Consultant Anesthesiologist, SGPGI, and Dr. Karan Kaushik, sir, Cardiac Anesthesiologist, KGMU, and Dr. Sorangshu Sarkar, Cardiac Anesthesiology, Max Hospital.
if he's here.
I don't think I have anything here to introduce Dr. Vijay, but
It's fine.
he's an alumnus from this institute and is doing a lot of pediatric cardiac surgery and doing other than also adult cardiac surgery. So over to you, Dr. Vijay. And this is on tetralogy of fallow connection, the bedside ventricle.
Good afternoon, everybody. It's always an honor to come back to your institute for any kind of meeting. Respected chair people. Today the topic is purely on tetralogy of fallow, right ventricle, and how the right ventricle behaves after tetralogy correction. I'm going to be like mostly clinical. I don't have many slides. I had sent out some questionnaires to a lot of pioneering surgeons all over India, and I will share their response as to how they deal with the right ventricle. You know, right ventricle, as the previous speakers enumerated, is a very difficult ventricle, a very poorly understood ventricle, and therefore you see so much of literature and so much of values and all that. The clinical outcome may not correlate with the numbers as far as the right ventricle is concerned. You know, for last so many years, as Dr. Shantanu rightly pointed out, that, we know the left ventricle a bit better than the right ventricle. We don't know how the right ventricle behaves. It's a very temperamental ventricle, And in this election year, if on a lighter note, for the last 10, 12 years, we did not know what to do with the Delhi's chief minister. And then we finally decided to jail. So we are trying, today there will be an attempt to see what we can do to improve RV function. So I'm not going to be very pessimistic about right ventricle function. And I'm going to shed some light as to what can be done after tetralogy correction to minimize RV dysfunction. One important data before I forget is what Dr. Shantanu pointed out from one of his papers, that the TAPSE after 4 years of follow-up in the patients had marginally increased from 15 to 16.3 or 16.4. So it was a very marginal improvement. The other thing that struck me was that his average age of tetralogy was 11 years. Is there a message in there? Is that the reflection of all tetralogies and all TAPSE that might be the same? I don't think that the answer is that the TAPSE is going to be similar. I think what he presented is a true data, but it is not relevant for all the ages. And therefore, the dictum that the congenital heart disease, irrespective of the diagnosis, should be operated as early as possible. So it will be interesting to see what the TAPSE would be if you operated on a tetralogy below 1 year of age, as the recommendation is all over the world. And if the later you operate the tetralogy, you will have very limited improvement in TAPSE. Definitely there will be improvement in symptoms, but the numbers will not be very encouraging. So that's a very interesting study by Dr. Shantanu. See, in the right ventricle, I think do we have a pointer here? Do we have? So the infundibulum is probably one of the very important areas when you are looking at it as a surgeon. You know that everybody, this is a subset which everybody, operates, the adult surgeons and the pediatric surgeons. Therefore, this is of extreme interest that you get this right. So in all of this of the ventricular septum, the inlet septum, the outlet septum, or the infundibular septum, the membranous and the muscular septum, the most important as far as the tetralogy is concerned is the infundibular septum. Here the resection has to be done as minimal as possible. You can work on the muscular and other areas, but if you want to minimize your RV dysfunction after tetralogy, you have to respect the infundibulum. The most you can do is not to excise. You must only do incision in this area. There's an interesting study from Netherlands, Germany, from multiple center, and this
interaction of the atria and the ventricle and the artery, the great arteries, and the ventricle with each other, right ventricle and left ventricle. It's a combination of all these factors which is leading to right ventricular dysfunction after tetralogy correction. Very interesting finding here. Although progressive RV dilatation is widely used in the timing for pulmonary valve replacement, this strategy does not always ensure favorable long-term outcome. In addition, longitudinal follow-up had demonstrated that RV dilatation is an unreliable marker or adverse events. So we tend to do a lot of these studies and we say RV volume has to be more than 140 QRS duration XYZ. And we take that as a kind of a guideline to do a pulmonary valve replacement. But pulmonary valve replacement does not actually reduces the incidence of death or RV failure. Yes, it does improve RV volumes, it does improve symptoms, and that is the reason why we do pulmonary valve replacement. When we were operating in Riyadh, every week we would do a pulmonary valve replacement. And the timing in which they would come would be anything between 20 years to 50 years. And but the important point is to understand that, you know, the numbers are one thing and the outcomes are another thing. So before you intervene, you have to really deliberate properly as to whether you should go for a pulmonary valve replacement or not, and what is the benefit of that. Again, as previous speakers pointed out, 2D echo derived RV functional change was normal. And this is Krishna Kumar, who's one of the finest pediatric cardiologists and usually speaks the truth and has got genuine literature. An analysis of RV function by echo is likely to produce unreliable data. So according to him, tissue Doppler index, imaging, especially the myocardial performance index and the systolic tricuspid angular velocity are more important factors in telling you about the RV dysfunction. I'll come back to the topic which I wanted to discuss. You know, three important surgical considerations when we do tetralogy of Fallot. The limitation of ventriculotomy and avoiding excision of the infundibulum muscle is the most important key factor. You know, if you are given a tetralogy at 3 months or 6 months or 12 years, the fate of that tetralogy as far as RV dysfunction is pretty much set because you can't choose the timing of the operation. But whenever you receive a tetralogy of Fallot, I think the most important surgical consideration as far as technique is concerned is limited ventriculotomy and avoiding excision of infundibulum muscle. This is in order of importance. And second importance is how you conduct your bypass, how do you spare the coronal branch. And the least important, I underline, it is the least important, use of monocasp and bicasp. People keep on banging about, look here, I made mono, bicasp, tricasp, and fancy things. I think we are wasting a lot of bypass run doing this. It is the least important. I would rate how you conduct your bypass as the second most important factor. What kind of cardioplegia you give. What kind of cardioplegia you give in infants, say 2 to 5 years, and what kind of cardioplegia you use for adult tetralogies, for example, where the physiology can be very restrictive. How you give your cardioplegia, what kind of cardioplegia you give. A very popular cardioplegia these days, obviously, is del nido cardioplegia. And I work with a lot of perfusionists, and 80% of them don't know how to make the cardioplegia correctly. Many of them, they do not know the exact dose, and they do not know in what pressure to give. So your fate is for RV dysfunction is already set by the perfusionist, knowingly or unknowingly. You know, the pressure for del nido cardioplegia, for example, is different than the pressure of custodial cardioplegia. How del nido would work in an adult tetralogy is very different from how it would work in infant tetralogy. So I'm just giving you an example as to RV dysfunction, is already set in at the time of the operation. Our effort should be not to worsen it or minimize it, and we should seek solutions for that. And I feel the conduct of bypass, myocardial protection, sometimes a small coronal branch which can be avoided is very casually sacrificed. RV distension, you would realize that many times when we give plegia, the RV distends, and we keep on continue to give cardioplegia. We are very very careful with the LV distension, because classically and historically we have been taught about how to protect the left ventricle. But if the RV distant, then it's fine. I think that's not correct. Sometimes you might wonder that why would the RV distend? Because there's a hole in the heart, there is a VSD. But generally the aortic valve cusp distends when you give cardioplegia and kind of temporarily blocks the VSD, and the right ventricle can therefore distend. These are important factors. When you open the right atrium to correct the tetralogy, I think your effort should be to look at the whole anatomy properly and also carefully inspect the tricuspid valve. Many times when surgeons with lesser experience or they are starting out, including myself, we have missed borderline small tricuspid valve. And now we can pick it up in the first go. As soon as we see a smallish tricuspid valve, you did everything right and you might have bad RV dysfunction and lose the patient. So you keep an eye on the tricuspid valve. 99% of the surgeons would not address tricuspid valve problems at the time of tetralogy correction. The tricuspid valve gets often distorted by the VSD patch. It gets often distorted by the VSD patch, and we accept mild plus regurgitation. And that needs to be addressed as well, because these all can cause RV dysfunction. The third thing is the PFO. I'm a big fan of leaving a persistent foramen ovale, and during my early years, it has prevented a lot of deaths. The patient has gone into low cardiac output, but the patient survived because there was right left shunting, because the PFO kept the patient alive. But you cannot leave a very big PFO, because literature has established that if you put in a big PFO, that will contribute to RV dilatation in the long run. I have worked with surgeons who do not create PFO because they pay attention to the rest of the operation. So, and therefore, a bit arrogantly, but obviously I do make cusp. I will come to this situation, I would make cusp. I say that these things are very important. The ventriculotomy, avoiding excision infantile, and the conduct of bypass. What is the geometry of the transnular patch? We can use these three kinds of patches. And the first, the second, and the third. You can see that the geometry of the transnular patch is also important. I mean, I'm talking about transnular patch and RV dysfunction because RV dysfunction is more commonly found in patients of tetralogy who require transnular patch, and therefore the integrity of the pulmonary analysis is a very important factor in maintaining RV function. And this patch, I am sure you would have heard that many surgeons like to leave a little bit of gradient. If you look at the third patch, the waist is a bit narrow at the annulus, and that would leave a little bit of gradient. They are not making the monocusp or a bicusp, but they leave that thing for a little bit of gradient. For the first patch, if you make a first patch like this, very near to the bifurcation, you will have bifurcation gradients, and that will worsen the RV function because there is a obstruction after the operation. And therefore, if you are putting your patch right up till the annulus, you would rather use the patch number 2. Look at the tip of the patch, which is broader, so you would avoid gradients. So these are simple things. This may not be very important in 10-year-old, 4-year-old, 5-year-old, but it will be very important for if you are operating on 3 months, 4 months, 5 months tetralogy with the transnular patch. One of the very honest paper from one of my friends from Melbourne Children, Nelson, they use the Sung technique for the construction of the monocusp. And by their own submission, and very honest submission, they found out that the PTFE membrane, they found it to be most preferred material for cusp. There was no objective assessment by echo to grade severity. They gave out all their paper, all their data that I think they would have done some 80 or 90 odd transnular patch with monocusp, and they gave the data where they showed that most of the pulmonary regurgitation is mild to moderate, even in the first or second, third year, when they're follow-up, which is a very good data, which is actually not correlating with the other data anywhere else in the world. We know that most of the monocusp, they wither away in 2 to 3, 4 months' time. They are good for 3 to 6 months, and therefore they are useful for people who believe in it. So, but he accepts that there is no objective assessment by the echo grade severity. If you are working with a very friendly cardiologist, he would generally grade your pulmonary regurgitation from monocusp as mild. And if the cardiologist is not very confident, he also says it's mild. Sir, ज़्यादा नहीं है, ठीक है, सब ठीक है. You know, so it's very, very subjective. And it's very, very right that they have been honest about it, that there is really no objective assessment by the echo grade severity. And quantification of valve dysfunction by 2D echo was also subjective and prone to bias. That's a very honest statement to make, and it's really appreciated. So we have to be not in the la-la land. We believe that everything what we do is perfect and will last forever. There is enough data now to show that PTFE membrane is now the best material to use as a cusp. In their, coming back to this thing, they have used bovine pericardium, they've used autologous pericardium. We have treated autologous pericardium with glutaraldehyde. And, we do Ozaki procedure as well for using glutaraldehyde. And Carpentier has been pioneer in doing mitral valve repairs. But if you look at his mid-term and long-term follow-up, for giants like Carpentier, their results are also not very great for mid-term results. So even autologous pericardium has its limitation. And that is also the limitation for Ozaki, no matter what people would claim, especially in children. And so the PTFE membrane is probably the most evolved as of now. And the rest of them are very prone to calcification and withering away. So we have not used any transsolar patches in this subset, whether it be infants or 6 months to 1 year or more than 20 years. But this applies only to tetralogy. When we do a REV or a Nikaido operation, then I always put in a monocusp or a bicusp, because the main difference between a tetralogy correction and a REV Nikaido correction is that you are making a ventriculotomy and excision is on the body and not on the infundibulum. And therefore, it is very important to put in a cusp in this kind of situation. The other area where you should put in a cusp is when you have a smaller PA, or when you have pulmonary hypertension, when you have MAP cusp, because that right ventricle does not take it kindly to, if with a free PR. So my take-home message is, because I thought it's only a 10-minute lecture, was asymptomatic RV dysfunction is very common. Length of ventriculotomy and minimal disturbance to infundibulum, most important variable in TAP patients. CPB, as I suggested, that these are very neglected operative factors which actually can do a lot to prevent RV dysfunction post-operative. TAP with or without cusp has no influence on ventilation times in our experience. In our series, we have not had very long ventilation times with no cusp. And I just said that in smallish PA and pulmonary atresia, probably we'll put in a patch. I tried to talk to a lot of the surgeons all over the world, or rather whatever I could get, 7 or 8 of them, and they were very kind to reply. And they are serious pediatric cardiac surgeons. When I say serious, they think about why and what, and they don't get carried away with the newer technology or fancy things. And when they find that the results are not great, they would actually share it. So my questionnaire to them was about 2 weeks back, when I came to know that I have to do this. I asked them these following questions. If it plays a role in reducing low cardiac output RV dysfunction early postoperatively, whether it affects long-term RV dilatation, apart from length of ventriculotomy, what protects RV or reduces RV dysfunction, because that information is important for our surgeons, and if you can do anything to better it, and choice of cusp material and preferred technique if you use cusps. And if you don't use cusps, then do you recommend use of in any particular subset? These were my questions. So the last point number 6, one of the surgeons said, is I do not use monocusp, and if he does use, then he will use PTFE or autologous pericardium. And he also believed it does not affect long-term dilatation or delay the PR. From Dr. Iyer, this is as such I have put it here. In standard TOF, I never use a monocuff cusp, and I do not believe that it also alters post-op course. In adults beyond 20 years, I put a bioprosthetic valve as long as the TR patch, as long a tap is required. And here it is an important thing. In adult tetralogy, I think one must try to put in a patch because the free PR may not be taken very kindly. One of the best surgeons I have come across from Riyadh, and he says he has given a good insight, and I completely agree that he says in the last point, it comes down to the material used in the cusp repair or replacement. If tissue engineering progresses to the degree that we have thin and pliable tissue for longer, then the cusp option will be attractive in all patients. So I don't have anything against the cusp. It is the nature of the cusp, the quality and the durability of the cusp is actually going to be the game changer. And again, a similar experience with the other surgeon from Jaipur. And since last few years, I have minimized the use of monocusp, replacing it with only minimal ventriculotomy with no cusp. The other important thing, as I said, was that always try to look at the tricuspid valve. So if you ask me, apart from the surgical consideration, I would emphasize a lot on maintaining hematocrit, the cardioplegia, how you handle the heart, apart from the surgical factors, and emphasis on looking at the tricuspid valve. I am excited about monocuspid in certain situations, but I would try to limit my ventriculotomy. That is how I would summarize. I think these are some of the things, in my view, can help you reduce a little bit of RV dysfunction. Thank you so much.
Precise presentation on RV dysfunction. Now, luckily, opportunately, I'll say our as an anesthesiologist, our concepts are only related to acute phase. And what I found a difference between the surgeons' concepts is that they are more worried about what happens in the long term, 5 year, 10 year down the line, RV dysfunction. But I can only tell you, I can only share that during coming off bypass, I fully agree with Dr. Shantanu, the point that what is the time to take off the things, means de-escalating the therapy.
Okay.
Those targets are very important. And one only point I want to emphasize is that if we understand that the RV is working in a low pressure system, and most of the parameters we try to derive also are based on RV function, and then we extrapolate to the LV function, because echo is not done all the time, every time. So, and hemodynamic changes of the LV we presume that RV is all right. But we must not forget that the lungs are very important, the PVR. Now, the PVR can get changed because of lung changes, which, the patient has already undergone. The fibrosis, interstitial fibrosis, or any other thing. He might have been given a lot of ATT, he might have received, just by the physicians and all those things. So, lungs might be contributing to the RV dysfunction. Much more is the area probably we need to concentrate on that. The session is open for discussion.
And also we expect for a borderline branch case, we try to put a focus point to tide over the acute case. Because for long term, always the PR will be significant. So molecules help us to tide over the acute case, especially in the borderline case, because in the borderline case, the PR will be passive. In that phase, it's Otherwise, long term, we have seen it's very responsible. One question I want to ask, what is there a size of VSD patch besides the size of VSD? Does it affect of RV? Like if you already case of a DOR, the complex staging and you put a big parallelistic patch, does it impact you?
Yeah. So I think your first comment was, I agree with that first comment that you would put in a borderline PA. That is what I'm saying, that you can use a cusp. I disagree with the second part of your argument that it will reduce your LA or early post-operative period, because I have shown in our experience and other experiences, our ventilation time is less than six hours for any tetralogy correction, except for a couple of cases. The third is that the VSD patch probably does not contribute too much. It is the nature of the anatomy. If you do a DORV VSD, just a DORV VSD, no ventriculotomy, nothing, you are likely to have more RV dysfunction. Then you do a simple VSD, or then you do a tetralogy. So if you look at the chances of RV dysfunction, the grade will be VSD, less RV dysfunction, tetralogy, and DORV VSDs. DORV VSD yeah, they will tend to have more because you will tend to use more transcellular patches in DORV VSD situations. Because it is more malaligned, your VSD is getting into the RVOT, and therefore by default, you have to put in a transcellular patch. The second thing which I actually forgot to speak in my presentation was that if you have a residual VSD in a simple VSD, and if you have a residual VSD in a tetralogy VSD, and if you have a residual VSD in a DORV VSD will trouble you like hell, even if it's like a 2 millimeter VSD. So never, accept a 2 millimeter, 3 millimeter VSD, residual VSD with the DORV VSD. You know why? Because the right ventricle is actually talking to the aorta directly, even through a small hole. Even if it's 2-3 millimeter. Whereas in the residual VSD, because the septum is not malaligned, you can actually ignore that 2 millimeter VSD and get on with life. So the importance of what subset you are operating is very, very important. I'll give you an example. If you do, whenever you expose the right ventricle to a systemic circulation, you are in trouble. That's why adult tetralogists come back to you, because they are failing, because the right ventricle can't take the aorta anymore through the big VSD. Similarly, post-operatively, if you have a residual VSD, the right ventricle is not going to take it kindly, and right ventricular dysfunction happens. And we are all focusing on cusp and no cusp, and less post-operative and early post-op and stormy period and all that. So we are actually digressing from that important point. So residual VSD can trouble you depending upon what subset you are operating. Yeah, correct. Yeah, I mean, most of the people would agree that if there is a significant MAPTA, you have to ligate it or coil it. Okay, that MAPTA will lead to pulmonary hypertension, and that is one subset where your returns are higher and all that, and you have a borderline PAs, as you said. These are some of the indications which I said that you must use a monocusp. But MAPTA cannot be left alone. We have had many situations. I can recall 5 to 6 in the last 15, 20 years I've been doing. We have operated on a tetralogy, and we are unable to extubate the patient. We had to go back, do a cath, found a MAPTA, coiled it, and we were able to extubate. And they had florid ET tube bleeding. So MAPCAS has to be seen properly. Even if you're doing Fontan or anything, it will bother you. It will cause low cardiac output, what you call as, a stormy post-op period as a result of no monocusp, So, just you get the hype out of that monocusp out of the, your system, and understand that there are so many much more important contributing factors. It is not about the art and the craft of everything. It is about, what kind of subset you are dealing with.
I would like to know something. So we are talking of not excising the infundibular for a very simple reason that infundibular function is very important.
Very important.
Stop them, construct them, analyze and you have done something on infundibulum,
It will trouble. Correct, correct.
So, how do you continue? So, from my learning, can you describe that? How are you going to relieve the parietal band phenotype from the infundibulum? Which area do actually you make anything?
So, if you look at the area, I mean, that reminds me of one of his questions. Go back to the diagram. I just, before I come, I forgot one important point that he asked me something about the VSD patch. I must just tell you, as a matter of interest, that when you are doing DORV VSDs or outlet VSD, try to make a small VSD patch. It should be snug. It should not be bulging like perimembranous VSD, because that will help you in supporting the annulus of the aortic valve, preventing further, So that, remember, small technical point, but otherwise it does not contribute to the.
How flattish should it be? Are you not scared about gradient it would be created?
No, obviously you have to be sensible about it. Yeah. But it should be, close to the annulus. Hugging the annulus. Outlet VSD, you can see the annulus and you can be close to the annulus.
Trying to support it.
Yeah, where is the diagram? I don't know. So I would actually, do you have a pointer? Infundibulum, I do only two things. I don't do, actually, I try to avoid infundibulum. And some people, the infundibulum is very long and narrow, and it is very hypertrophied. So you can't actually ignore it, because then you have to compensate it with a patch or excision on the other areas. But still, I would rather, tend to be minimalistic on the infundibulum. So what I do is what we call as cuts. Just make incisions, parallel incisions on the infundibulum in that area. This cursor, this area, this is the infundibulum area. So you make cuts in that infundibulum area. And the other thing I sometimes do is I take a scissor and put parallel to the infundibulum and cut out a slice of the infundibulum like a cheese slice, very thin, but you don't go deep. If you go deep, you can hit the first septal perforator. If you go very deep, you can get out of the heart, which I have done about 15-20 years back. So then just leave the infundibulum alone as much as possible. Do not excise, incise. And if you do all these things, there is no reason why your post-operative should be very this thing. And if it is, then it is some other factors which we have as a surgeon sometimes miss it, So.
One question about cardioplegia you were mentioning. So if we get, what is your experience about cardioplegia being washed out and activity returning early when you are operating at tetralogy?
Okay, so I blame the perfusionists for not making good cardioplegia. But it is many times it happens because of the MAPCAS. The heart gets warmed up. If you are giving cardioplegia and if you are not watching the cardioplegia can leak into the left ventricle or the right ventricle. Aortic valve is dilated in tetralogy of Fallot. Aortic root dilatation is known. The older the tetralogy of the DORV, it is dilated, and they are incompetent. And the natural history of tetralogy correction or DORV correction is that the aortic root kind of dilates with time and becomes regurgitant. And many times it is regurgitant. So the plegia is leaking down, and you feel that you have given the full dose. So whenever I am dealing with adult tetralogy, I would rather give an extra dose, of cardioplegia. Secondly, if you're using adult tetralogy, I have moved away from Delnido. We started using Delnido in 2010, and it was a big fan of Delnido, but for the last 3 to 4 years, it is not good because I have not been able to explain certain sudden deaths. And we have spoken to other surgeons, and they are also moving away from Delnido, especially in adult patients. And it is there in the literature that the value of Delnido is there in infants and smaller children. But when you have hypertrophied hearts, tetralogy of Fallot, adult cases like Hookham cases and all, when we do, then I would rather go for custodial. In fact, even when we do it here,
And in some cases it is unavoidable, especially in older tetralogy. So if you are coming out with a filling pressure of 11, 12 CVP, then you rather open the pleura right and left and put in a drain. If you are extubating any child with a CVP of 10, 11, you better be careful. Even if you can extubate and claim that I have extubated the child within 6 hours, the next day he can go into low cardiac output. So you never wean off the inotropes. You give full respect to the RV. Extubation is never a criteria for achieving the goal. It does not mean RV dysfunction is gone. We have had a recent operation where we extubated, and the cardiologist is here. He picked up a very low TAPSE on the RV in the Senning, and the patient was absolutely fine. But we were unable to explain why the child was tachycardic for 137, 138 heart rate when the child is 5 months and should be 110 or something. As we started Milrinone, and the heart rate settled that night. So echo is very, very important. Repeated echo by a very, interested cardiologist, which is very difficult to find these days, is very, very important for your good post-operative recovery. You pick up the problem in the OT or as much in the ICU. If you go beyond that, third, fourth day, you are looking at saving the baby or saving the child. You are looking only at catching up. You pick up your problem. We have a TOE for all children. We do a TOE. And we pick up 95, 97% of the problems on the thing. But that doesn't mean all problems are solved. You might exclude all intraoperative corrective factors, but RV dysfunction can even sustain for post-operative, and therefore transthoracic echoes repeatedly in these subgroups are very, very useful for, if, for example, you get recurrent pleural effusion. If you found that on the echo that you have RV dysfunction, you might continue your Lasix and Milrinone and other things to support, and you probably have less incidence of effusion. Probably you are getting more effusions because you are not aware. The patient has gone to the ward, and then found out there is a collection. It is because nobody has seen that patient for the next 3-4 days. And you suddenly find that, it happens to all of us. We have had patients who go home and come back with collection. So RV dysfunction, as you correctly said, the TAPSE is hardly increasing. Probably you went out that time when I was praising your article. It was that the TAPSE has not increased in your series of patients. From 15 to 16 was the average after 4 years. So the TAPSE is really not increasing. It means that the RV is buggered off before the operation, And that is the reason why people are recommending it to, treat tetralogy early. Because RV dysfunction starts in. The longer you delay the operation, that is the philosophy of operating on tetralogy early in life, not in neonates. They have found that it is not very effective in neonates because the PDA tissue will cicatrize and cause bifurcation stenosis. So Richard Jonas et al., they started doing a lot of neonates tetralogy but did not find it useful. 3 to 6 months is a good time to do tetralogy. Probably you'll get best recovery. Your TAPSE may be normal after 4 years, but you studied, your age group was 11 years. So the TAPSE improvement might be more encouraging if we try to do tetralogy early. That is something which can be studied, When you can compare 1 year, 2 year tetralogy, which you do, to 11-year-old tetralogy and see 1 or 2 years follow-up data, whether numbers are better or not. Symptoms will be better. Symptoms is never an indication for everything.
I think we have discussion. Thank you, Dr.
Thank you.
Thank you, sir.
Very quick. Dr. Veda, you have quickly to
I would actually, I would actually use custodial if I had my way of, the money is not a factor. Custodial. Even in the tetralogy, even in a VSD, for example, and even St. Thomas's, if you are repeating the cardioplegia and delivery is good, you use St. Thomas's. But we are still using Del Nido, and we are good up to 60, 65 minutes. You know, when you are longer, then because I have to choose, I can't use custodial in all the patients because of the cost factor. So we still use Del Nido. In selected cases where my clamp time is going to be 2 hours or more, then I use custodial. I just said, custodial it is, I think Rajkumar will be able to tell better. As far as I know, custodial will be 80 to 100. Yeah, millimeter of mercury.
That should be monitored in the
Monitored. Yeah. You can give it from the head end, or you can give it through the perfusions, but you need to monitor the pressure, isn't it?
what should we have to take
I don't know about that exactly. So, as I said, for custodial and Del Nido, it is well enumerated the cardioplegia pressure, you know. So you give it at that pressure. I'm not understanding, exactly what you want. There is not one solution to prevent RV dysfunction through cardioplegia. This cardioplegia pressure is for, for all the patients.
saying the delivery pressure will be same with the every
Because there is blood, it is more viscous. So you need a higher pressure to push the cardioplegia to the system. Crystalloid is crystalloid. It can move freely, whereas Del Nido is thicker, 4:1. Therefore, you need a little higher pressure. It's just normal. I have not set the pressure. Pressure it is in the. What would you suggest? What would you suggest? Okay.
It should be near about 140 or 150.
Okay. Okay. I take your point. I respect your point, but we will continue to do what we are getting good results in. Sure. Thank you. We'll look into it.
I request Professor S.K. Agarwal to kindly felicitate our speaker, sir, Dr. Vijay Agarwal, sir. I request Professor S.K. Agarwal to kindly felicitate Dr. Banani ma'am and Dr. Mukesh Tripathi, sir, also. I request Dr. Varuna to kindly facilitate. Dr. Sarkar. Yeah. Thank you. Thank you all.
Everybody is tired after a long set of lectures and discussions. We would be breaking for a short lunch because we are already 1.5 hours late. So I would request that we at least save some about 30 minutes time by coming back at 2:30, and we finish the lunch in next 30 to 45 minutes. Thank you. Yeah.
हेलो, ये मैं आपकी बात करा रहा हूँ, है ना? हेलो, मैं आपकी बात कर रहा था। वो कह रहा नहीं मिल रहा है, लेकिन अभी कोई आएगा तो मैं कॉल लाइन पे ले रहा हूँ, बात कर लीजिए। शशांक, जरा बाबू ये इनको इन्फॉर्म कर दो। जी बस, ये एक्चुअली फ्लैश के लिए चलाना था, बट वो चल ही नहीं पा रहा है। कुछ करना है क्या? अच्छा, फोटो
उधर देख। कैसे आ रही? थोड़ा ही रुकना है। थोड़ा सा सेंटर में हाँ, दोनों में।
हेलो, कह रहा हूँ पीजीआई में हूँ, यहाँ पे एक कॉन्फ्रेंस थी ना, बताया था तुमको, उसी में। अबे शाम हो जाएगी, कहाँ हो? अच्छा, मस्ती। चल ठीक।
सीधे यार। अच्छा, बैग लेके है।
मैम आप आ जाइए।
और
एक मिनट, इधर से
मैं तो
just-
सीखूंगी कुछ। थैंक यू। फूल मत लेना। नहीं फूल नहीं। देख लो जैसे ठीक लग रही है। अंशु दीदी आ रही है ना।
और खाना खिलाता हूँ और
नहीं चल रहा है ये, एक एक फ्लैश कर, एक मिनट आएंगे जरा, एक मिनट आएंगे। बना अच्छा अच्छा बना रहे नहीं रहा था, एक मिनट आप बनाएंगे। चलो उसमें वो है वो इमेज है क्या बेसिकली, ये बेसिकली प्रोडक्ट की इमेज है। वो तो आपका तो कोई दिक्कत नहीं है, इनके में दिक्कत है ना, इनका ये कौन सी फाइल है ये तीनों फाइल है। अब मैं इसको सोचा कि स्लाइड शो बना दूं, हाँ बट वो इसमें ये तो मेरा वो खुल गया मेल, इधर था पीपीटी है ना, ये पीपीटी है, हाँ ये बंद कर दीजिए, कट करिए यहाँ से भी। नया फाइल बनाना होगा, ये फिर से इसको पहले मिनिमाइज कर दें, इसको भी कट कर दो, फिर से नया खोल लो, फिर फ्रेश कर देंगे। न्यू ब्लैंक प्रेजेंटेशन पे क्लिक कर, न्यू कर लिया, कट कर दो इसको। Blank presentation। वो चारों फोटो इसी पे साला रिपोर्ट कर लो इसको ना, आ गया। मोर नहीं ऐड इसमें थोड़ा डिफरेंट खुल रहा है। अरे वो डिफरेंट क्या, नया है ना, हाँ ये ना, हाँ सब एक ही में आ गया क्या? नहीं ऐड का ऑप्शन है, न्यू स्लाइड, स्लाइड का ऑप्शन बैक करी न्यू स्लाइड सब कुछ, इंसर्ट नहीं, न्यू स्लाइड, हाँ न्यू स्लाइड में इसको डिलीट करो, ब्लैंक कर दो ना, रीसेट लेआउट में जाकर ब्लैंक कर दो। ऑप्शन है, क्या पहला क्या उठाया था, ये अच्छा पहले वो लग गया, कोई बात नहीं, एक एक करके उठा, हाँ तीन उठाइए, फिर क्या हुई, बड़ा कर दीजिए, थोड़ा सा छोटा, ठीक है ठीक है ठीक है, ये हो गया। न्यू स्लाइड कहाँ गई थी, होम पे आके न्यू स्लाइड, उसमें डिलीट करिए, डिलीट करने की नहीं, उठाए डालो उसमें, ऊपर ही आ जाएगा लैप ऐसे, टाइटल हटाएगा नहीं तो इसका एरिया भी नहीं जाएगा ना, ये वाला बॉक्स नहीं हटेगा, हट जाएगा, नहीं हटेगा, करिए देखिए, हाँ हट गया तो बहुत टफ हो गया ना बस। अच्छा है ये वाला, डेफिनेटली डेस्कटॉप पे कर दो, डेस्कटॉप पे कर दो, स्लाइड शो डाल दिया नाम, बस मिनिमाइज करके देख लीजिए, सेव है फाइल तो सेव है ये ना, बस इसको फुल स्क्रीन करने के लिए क्या करते हैं यार, इसमें कहाँ होता है ऑप्शन, व्यू में स्लाइड शो है ना, फ्रॉम बिगिनिंग, उसने ऑटो मोड पे नहीं चलेगी क्या सर?
ये आपको प्रोजेक्शन देख रहा हूँ,
प्लीज देख तो नहीं रहे सर, लेकिन फिर भी बताइए सर,
मुझे वो लैपटॉप एक बार,
आपको प्रेजेंटेशन इसमें रखना है?
हाँ, नहीं मैं अपने लैपटॉप से ही करूँगा,
अच्छा
तो मैं वही चेक करना चाहता था कि एक बार
इसी में नेक्स्ट करके ऑटो कैसे चलेगा, ऑटो होता है तो टास्क
इसको कट करो बता।
नहीं नहीं, अपने आप से समझ गया। See, all right. One से ऐसा लाइक कर लीजिए। नहीं नहीं, आप कट करिए, इसको कट करिए, शुरू नहीं हुआ।
ऐड एनिमेशन में जाएगा ना।
ये भी कट करिए, ये भी कट करिए। ऑटोमेटिक लगाता है सर, एक मिनट। ये जाती है। सर HDMI भी चाहिए वर्किंग शायद।
HDMI
है ना सर? ओके ओके, इसमें क्या लिखा हुआ है ना?
इसमें लोड करना।
सॉरी,
आप इसमें लोड
जी
करना।
दे दूँ? हाँ, उस पर डाल दिया तो हम डेस्कटॉप पे बंद कर दूँ, इसका बंद कर दूँ, ऐसे इधर लगेगी। पोस्ट होगा। हाँ सर, आगे देखते हैं। हाँ जी सर। तो इसके बाद जो हर्षित जी का है, इसके बाद शायद
किसका?
हर्षित खाली।
अच्छा ठीक है,
आप
मैं एक बार चेक कर लूँ।
हाँ चेक कर, बिल्कुल आप चेक कर लीजिए। इसके बाद बोला आपका कब है सर?
मेरे टाइमिंग के हिसाब से तो शायद 2:30 था।
मुझे भी पहले इनकी
या बाद में।
मैं देखता हूँ सर, शेड्यूल है मेरे पास। सर मित्तल सर, हाँ ठीक है, हाँ 2:30 है, कर देंगे, फिर आधे घंटे का लेट तो चल जाएगा। जी, आपसे, हाँ आपसे पहले सर आपका है। और अभी हर्षित खरे जी का जो है पोस्टपोन हो गया था, पोस्ट लंच हो गया है, दरअसल विजय के बाद उसका फिर लास्ट में होगा वो डिले हो, तो हर्षित खरे जी स्टार्ट करेंगे, फिर आप करेंगे, ठीक है लंच कर लीजिए
सर लंच में छूट गया मेरे से, एक बार चेक कर लूँ सिस्टम, बाकी थोड़ी कनेक्ट हो गया।
इसमें मैं आपका नाम डाल दूँ स्लाइड पे, मतलब याद रहे।
डेस्कटॉप पे है ना? कहाँ यहाँ पे डालना है?
नहीं डेस्कटॉप पे ही। कंफ्यूजन मेरे बहुत सारे, अभी और शायद कोई एक आध लोग डालेंगे ना कहीं। ठीक है, सब्जेक्ट फीडिंग का नहीं है।
ये डिस्प्ले
इसमें स्क्रीन में क्या था?
ये वाला है,
ये बात
हाँ हाँ ठीक सर।
स्क्रीन यार
मैं पूछता हूँ। ये इसका डिस्प्ले होगा आई थिंक ना?
नहीं, इसी का है, एप्पल का
अच्छा
नहीं।
यार तो इसी का
अच्छा, तो फिर डिस्प्ले
डिस्प्ले आ रहा है बट
यहाँ पूरा
कंटेंट ओपन कर
पूरा कंटेंट यार
अच्छा नहीं हो रहा है।
मतलब कुछ मूवमेंट हो रहा है जब आप ओपन करें, बट वो स्क्रीन पे अब वॉलपेपर ही लगा हुआ है।
डिस्प्ले को सेट करना
तो स्क्रीन शेयरिंग
वाईफाई के लिए कुछ नहीं इम्पैक्ट कर सकते डायरेक्टली जो वाईफाई चलेगी कंटिन्यूस हाँ
सर आपकी प्रेजेंटेशन पीपीटी लेते हैं पीपीटी है हाँ पीपीटी मेरे को भी नहीं है। हेलो अरे शिव भी आए हैं क्या आए हैं कि नहीं अरे तो फिर आप बता दीजिए चलिए ठीक है कहाँ के चले गए हैं अभी जो है अलग प्रोग्राम कर रहा था
अच्छा आ गया
क्या शो था
स्लाइड शो जब ओपन करना चला रहा है
ओके
तो वैसे भी है ना कि कोई भी और विंडो तो दिख नहीं रही अब स्क्रीन पे
स्क्रीन के और फंक्शनिंग नहीं दिखी बहुत अच्छी बात है
पहले रिहर्सल से सही है
हाँ तब इतनी देर परेशान का टाइम वेस्ट होता है क्या करें?
टेक सपोर्ट के लिए अमित को बुलाया है मैं शांत खड़ा है शांत कुछ नहीं खड़े अच्छा यूट्यूब पे जा रहा हूँ और माइक बंद